You don't hear now. I gave it to Olainka. Olainka, where's the vote? Olainka.
Okay. Good afternoon, good morning, everyone. And apologies for the slight delay. I know it's very hard to compete with tea break, but I would like to crave your indulgence just for the next 10 minutes or so. First, I'd like to thank the chairman, the executive committee members, as well as all the other members of the society for granting me this opportunity to spend these few minutes with you today. My name is Dr. Kelechi Ohiri. I'm the Director General of the National Health Insurance Authority of Nigeria. And it's a great opportunity for us at the NHIA to be engaged and working on something that is of critical importance and interest to the society. And that's why I feel like today's presentation is not just one for information, but it's also one for advocacy and solidarity in tackling some of the biggest healthcare challenges that we face in Nigeria. As the theme for this annual scientific conference is sustaining quality maternal child health in a challenging economy, there are two things that come to bear in this very interesting title. One is the issue about maternal health and maternal mortality. As most of us know, that this is one area Nigeria hasn't done very well in. And the second element of it is the issue about the economy. Again, we're in very challenging times in Nigeria. And very few organizations like the National Health Insurance Authority straddle this intersection of health outcomes and financial protection, which has become more important at a time like this. So my discussion today is going to be very brief and is centered on three main areas. The overarching theme is to speak about the program that the NHIA has begun to work on enhancing financial access to care for women. And so I'll speak to the rationale, I'll give an overview of what the project involves, and then I'll take some time to advocate for what our collective roles and responsibilities will be. Many of us heard the Coordinating Minister for Health and Social Welfare make an announcement at the Joint Annual Review of the Health Sector that made a lot of waves. It was said free cesarean section in Nigeria. And of course, many of us may have met that announcement with reservations and skepticism. And hopefully, whereas for shock value, that made a lot of impact. But I think the reality we face and the solutions to addressing those things are a lot more nuanced. And hopefully, there'll be a clarification and an elucidation of what this entails. We know Nigeria has high maternal mortality ratios. That's not new to all of us. This is preaching to the converted. But we also know that beyond that, inequities exist across the country. Some places are worse off than others. So I will not dwell on this, but just the starting point and the rationale for engagement is the fact that whereas every country, including Nigeria, wants to go the path of universal health coverage, it's important that we also address what has become a critical emergency, which is the high maternal mortality ratios. And so what we did is essentially to partner with the Ministry of Health to see how can we enhance financial access. We all know about the 3 delays, right? The delay in seeking care, the delay in reaching care, and the delay in receiving care. And we've had many instances of people showing up at our practices. Maybe a woman is bleeding, suffering from postpartum hemorrhage, and she shows up but has nothing to pay for it. And many of our doctors have to make a very difficult ethical decision what to do. Many of you in your practices have seen yourselves having to underwrite or pay for people, or in some cases people are turned back and they die. So what can we do? So one of the things we looked at was the National Health Act. The National Health Insurance Act of 2022 set up the Vulnerable Group Fund. And in defining who is vulnerable in our society, it listed several categories, including those who do not have the resources, displaced persons, disabled persons, etc. But in addition, we looked at women who are at risk of dying as a group that is acutely vulnerable. And the question was, why can't they be included as part of those protected financially? Now, insurance works in a way that it's about managing risk. So when the outcome is certain, you can't insure the person. You don't insure a car at the point of the accident. So for this to work, we deliberated and came up with the fact that first, what we need to do is 3 things. First, keep the person alive. Before we start arguing as to whether the person has the funds to cover or not cover, but somebody has to pay for the care. Secondly, what do we do to ensure that they have access to a full suite of maternal or reproductive health services? And thirdly, what do we do, particularly in the challenging economy that we have, to ensure that they have access to financial protection through health insurance? So we can't just say, let's go, come back where you're enrolled. You can't just treat them now and leave them, and something happens to them, they have to come back again with having no financial protection. And thirdly, you can't just address only the issue without looking at things in a more comprehensive manner. And so that's why we came up with this. So the outcome is that, one, we hope that we can reduce maternal mortality. We also hope that we can insure people and give them financial protection. So what did we do? So first we looked at and we requested for data from all the tertiary hospitals and wrote to all the states for secondary data, and we ranked some of the facilities. The question being, where do women die? Where are there many births? And where are most of those complications? And so we ranked them and decided to start the pilot with about 11 federal teaching hospitals and some general hospitals across the country. And so we kicked off this intervention in August. So far, over 1,526 maternal complications have been addressed. We've also begun to enroll them in health insurance. And beyond maternal mortality reduction, but I think it's important to learn here, the aim is not just to focus on this person, but the aim is to go nationwide, which is every referral facility in Nigeria that is accredited and empaneled by NHIA, to ensure that when women come up with any complications, the 5 leading complications we know, hemorrhage, sepsis, prolonged obstructed labor, eclampsia, preeclampsia, and post-pregnancy complications like post-abortion care, etc., that at that point of presentation, we provide the guarantee as NHIA that go ahead and treat the person if your facility is accredited, and then we will pay and reimburse for that. And for that, we've partnered with independent third-party administrators as well to verify claims and do that. And I think this is very critical, because in our respective practices, we encounter this on a day-to-day basis. I'm short for time, so I'll run through quite a few things. The second thing that we decided to do was look at the complications and the morbidity that arises. And we started a fistula-free program where any woman in Nigeria that has obstetric fistula are present in any of the centers where that surgery or treatment can be provided. We do exactly the same thing. We pay and then we get the woman insured. And so we started with the 4 national obstetric fistula centers in Katsina, Ningi, Bauchi, Edo, and Ebonyi. And now we are working with over 22 centers across the country. So far, over 1,000 women since this program started in August have not just had treatment or surgical correction of the fistula, but have also had those claims paid for by the NHIA. And in addition, about 735 of them have been enrolled, and some others are currently being enrolled. So these are 2 programs that we feel are important. It's particularly important because of the high maternal mortality ratios we have. It's also important because right now, with the economic situation we find ourselves in, Nigeria with high out-of-pocket expenditure, it means that people who are poor cannot afford this care. It's not just a burden on the families, but it's also a burden on the providers, who in many cases cannot turn people back and are having to bear the disproportionate cost of doing so. So these programs have a dual-pronged approach. So finally, why am I here today? Well, first of all, when we started, we had an advisory committee that had 3 of your members, Professor Membasi, who is the host today, Professor Galadanchi, and a representative of the Society of Obstetrics and Gynecology, who provided advice to us as we started the program. But beyond that, it's also important that we partner with the society and with its members, because this cannot be successful without your buy-in. Because you are at the front lines, you see the patients, you see when they present. You're also the custodians of the code of conduct and practices amongst peers. One of the biggest questions that were asked was, how are we sure we're not creating a perverse incentive for supply-induced demand, particularly when the news around cesarean sections went on? And I'm always a firm believer that the best way to regulate is self-regulation. And that is one that the society can nudge its members, that we stay true to our practice and ensure that this is successful, that those that are in need, and only when medically necessary do we provide these services, that we will verify claims and we will pay for. And on the part of the NHIA, this is just the beginning of a consultative process we're undertaking. We've already reached out initially. We've started, we've learned lessons, and we're getting stronger and improving the program because we feel that it will help all Nigerians. This is not a start-stop program. This is one that will have a national scope, and this is one for which significant amount of resources are being mobilized, including NHIA's own funds, to make sure that this is a priority area that we cover. So with that, I'd like to say thank you for the opportunity to speak. I look forward to your collaboration. If there are questions, happy to answer, and I'm sure that we'll have more and more opportunities to interact. Thank you very much.
Thank you very much, sir, for keeping to time. We'll just take one question because we are running really out of time, and a lot of the sponsors have really come and shared their disappointment at not keeping to time. So we'll just take one. Yes, just one question, please. And we're going to take just one question from subsequent presentations because we are really short for time. Please, can you ask your question, please? Is the microphone there? Okay, take 2 together, please. We are really short for time, please.
Thank you, Secretary.
And make your question short, sir.
Thank you. Thank you, DG. This is very exciting. I'm happy about that. I have just one question or two. How are you escalating this to the state's insurance companies or I mean state health insurance agencies, because it needs to spread. The second one is, from our discussion here, is it possible for you into your cancer program to also include cervical cancer, especially those ones that are treatable, means that we have been diagnosed that they have a pre-cancer, and if they don't treat, it will advance to cancer and kill them. Thank you very much.
So I can take both the questions, the answers together.
Okay, thank you very much. I'm Dr. Ashuru Ladan, the CMAC FMC Burning Kebbi, and the coordinator of the program in Kebbi. I want to share some of our observations.
Please be brief. Please be brief. Please.
This program, so one of our challenges is enrolling patients, because the mode of only identification is NIN. And some of the women coming to our centers, they are not registered with NIN. And we have instances whereby we initiate treatment and some of the patients will die. So I want to request if we can add another form of identification. We have observed majority of these women have voter's cards. Can we use it as another form of identification so that we'll be able to submit our claims and we'll be able to, so this is my okay,
thank you very much for those two questions, and I know we're short of time.
Please go
on. On the first question about the states, they are very much involved, and in fact, just because I was rushing through it, once those women are treated, the next thing is to work with the state health insurance agencies to enroll them, so that these are part of the benefit package, so that a subsequent pregnancy is covered. And beyond that, any other ailment in the benefit package is also covered. So, and we are working very closely with the state health insurance agencies across the country to effect this. Sir, your question about identity is something that's really important. And what we have seen is that in many areas, it's a challenge. The country is moving towards identity. And this is also a form of identity inclusion. However, not having an NIN is not a reason to not treat somebody. That is not a prerequisite for treating. But it's important for us to strive towards that, for accountability and transparency of what we're doing. So what we have done at NHIA is working with our state offices to partner with NIMSI. And very soon NHIA will begin to be able to actually enroll people into NIN through the MOU that we're having with NIMSI. Some facilities already have that. But I think we all want to know that when we say 1,000 people have received something, or 10,000 or 20,000, we want to be sure that the identity is clear and that there is full transparency and accountability of those data. That's why we are moving towards that. But I will repeat, it should not stop somebody from receiving treatment. Ex post, we may decide to do that. And where it's not possible, we have used other identifiers, but while we continue to nudge people towards using NIN as a form of identity and verification. And Professor Mbasi, thank you for coming. Any difficult questions you have? Professor Mbasi, who has been one of our pioneers in this program, is also able to address that, and we've relied on his counsel as well as that of some of the other members of the society. So thank you very much.
Thank you very much for a wonderful presentation. Thank you, we appreciate, and I know you have a flight to catch. We're going to take Hatch Technologies now, and the speaker is, I think we have two speakers. One is Dr. Ibrahim Awowole. They're going to be talking 10 minutes, two presentations. Please keep to time because we're running quite late now. Point of care ultrasound scan, gaps and opportunities for improving maternity health in Nigeria. I know you're a wonderful speaker. Please try and keep to time, please.
Just to say that Hatch Technology sponsored the Jotters, so we're grateful to them. So
thank you very much. So please go ahead.
I'm trying to control the slide.
Point towards the laptop, towards the
Okay, good morning, everybody. I'm Dr. Ibrahim Awole from the Obafemi University, and I'll be discussing with us today point of care ultrasonography gaps and opportunities for improving maternal health in Nigeria. So, the Sustainable Development Goal 3.1 aims to consolidate on the MDG 5A. In 2015, at the end of the MDG period, global maternal mortality rate reduced by 44%. Though we did not meet the target of reducing maternal mortality rate by 75% as stipulated in 2000 when this started, it was still considered as significant progress, and the need to consolidate on that led to the development of SDG 3.1. However, we must not lose track of the fact that at the end of the MDG, Nigeria was actually one of the few countries that was classified as having made no progress in reducing maternal mortality between 2000 and 2015. We are less than 6 years to the end of the Sustainable Development Goal period now, and the WHO has categorized, the last report from WHO says our maternal mortality ratio is above 1,000. That makes Nigeria one of only 3 countries in the world with the maternal mortality ratio greater than 1,000. And in fact, at the moment, almost 1 out of every 3 pregnancy-related deaths happens in Nigeria. So, with that background, we look into a transformative approach that is based on the use of point-of-care ultrasonography. At the moment, technology is improving rapidly, and ultrasound machines are becoming very portable with very high resolution. Point-of-care ultrasonography is defined essentially by 2 characteristics. The first one is that it is performed by the clinician. You don't need to wait for a radiologist or specialist in radiodiagnosis to come over. And the second thing is that it is performed by the bedside of the patient or in the consulting room. These 2 key features define point-of-care ultrasonography. And it leads to the generation of results that helps the clinician in taking decisions. In fact, it's been advocated that in obstetrics and gynecological practices, because of our emergency-prone tendencies, point-of-care ultrasonography should now be considered as an extension of clinical examination. It should be that available that we must use it as if we're just taking history and examining the patient. What are the roles of point-of-care ultrasonography in OBGYN practice? It can give us immediate results, rapid assessment of the patient, early detection of complications. It is on record in literature that complications happen globally all over the world. What makes the difference in whether the patient will die or survive depends on how early the complications are addressed and how quickly the patients are managed or referred. And so, talking about referral, the use of point-of-care ultrasonography is also a veritable triage tool. And you can use that to determine whether the patient will need a laboratory test or whether the patient needs expert counseling or, in fact, surgical intervention. Patient experience is also better. I'm sure in our hospitals, we will see that oftentimes patients with maybe antepartum hemorrhage ask to go to radiology department and then join patients who have non-emergent indications for ultrasonography on the queue to have the procedure done. If we adopt point-of-care ultrasonography, it will eliminate all this delay. A case in point, for example, is in the case of ectopic pregnancy. So for ectopic pregnancy, 4% mortality associated with ectopic pregnancy. In low and middle income countries, this has even been said to be about 8 to 10%. Point of care ultrasonography is being proven to reduce the incidence of rupture of ectopic pregnancy. And we know that this is one of the hallmark prognostic indices in ectopic pregnancies. The WHO reported that there are about 23 million cases of abortion globally. And we can imagine the magnitude of intervention that we can do if this diagnosis can be made at the point of presentation. In the second trimester of pregnancy, we also have room for point of care ultrasonography, especially in the management of patients with antepartum hemorrhage, malpresentation, confirmation of fetal viability. Some of us will have had experiences where the patient was diagnosed with IUFD, only for the woman to deliver a live baby. If point of care ultrasonography had been readily available, then such incidences will have been reduced to the barest minimum. It is almost impossible to perform an instrumental vaginal delivery when you have not accurately determined the position of that fetus. Sometimes it is in doubt, and in fact, you cannot perform rotational deliveries if you are not sure of the position. This is also where point of care ultrasonography augments clinical practice. So what are the requirements? Expertise in performing ultrasound scan by the clinician. There must be training protocols and guidelines available. Steady electricity. You also preferably will need portable devices that you can move around. And if you look in terms of the economics, point of care ultrasonography is being shown to be cost effective. It reduces the waiting time, facilitates rapid decision making. It reduces the workload on the sonographers and is being shown to also reduce perinatal and maternal mortality. That was a skip. So what are the gaps? The gaps in point of care ultrasonography in Nigeria, in the first instance, under staffing, clinicians are probably busy. Radiologists and sonographers are short in supply. The brain drain that is currently ongoing is not helping matters as well. Appropriate protocols to know what to use, what to do, how to do it, when to do it. Electricity supply could be unstable, and in fact, there is lack of equipment to use. 2 years ago, we published this study about the practice of ultrasound in accredited centers. We surveyed 40 facilities. Out of these 40 facilities, 20 of them were teaching hospitals, and 16 of them were federal medical centers. So we can say these are hospitals at the highest level of OBGYN practice in Nigeria. 75% of them, in fact, had annual deliveries more than 1,500. And what did we find? More than 50% of these hospitals did not have an ultrasound machine in their OBGYN department. Only 4 centers had a written protocol for ultrasound scan in obstetrics and gynecology practice. Despite some of them having machines, 60% of these centers has not had anybody that is trained to use the machine formally. And almost 2/3 of every center that we contacted expressed their desire that they would really like things to change in order to improve maternal health. So the summary of barriers to point of care ultrasonography from that study is that ultrasound machines are not available in obstetrics and gynecological departments. Where they are available, there is lack of appropriately trained personnel to use the machine. I'm sure many of us say, oh, the ultrasound machine is bad, it cannot see anything. But it's because we're not properly trained. And where these two are available, there is no protocol to guide on how best to utilize this. So, ladies and gentlemen, this is where the opportunity for intervention comes. In order to address the gaps, we must establish collaborations for sustainable development between public and private organizations and non-governmental organizations in the distribution of point-of-care ultrasound machines, training of personnel, provision of support services, and development of protocols and guidelines. And one of these collaborations is what I stand here today to introduce to us between Arch Technologies and the Society of Gynecology and Obstetricians of Nigeria, SOGON, in addressing and utilizing these opportunities. So my presentation will end here while I invite Mr. Sema Sopko from Arch Technologies to present the second half of this talk on collaborations between SOGON and the organization on the use of point-of-care ultrasonography. Thank you for listening.
Thank you very much. Apologies, sir. You have just 10 minutes for your presentation. Please don't be offended. Please.
Thank you very much. First of all, I would like to thank the leadership of SOGON for giving us this opportunity to partner to see how we can drive access of these products and reduce maternal mortality. So I'll just do a brief on what Hatch is, and I would now go into the intervention. It shouldn't take more than 7 minutes. Hatch Technology is a non-profit organization that originated from Nest 360. So Nest 360 is an NGO that is focused on neonatal care. So for the past 4 years, we've been very big on neonatal care. As a matter of fact, we just did a launch of a project for distribution of CPAP. The minister just launched it on Tuesday. So now we're going into maternal because you cannot talk about neonatal without first addressing the issues with the mother. And that's where the conversations on point-of-care ultrasound. Now our mission is to transform the way maternal and newborn devices are distributed. And by distribution, it's beyond just going to drop equipment in the hospital. We're looking at how comprehensive, from the training to the decommissioning and all of that, to ensure that this impacts on the patient and improves on outcomes in hospitals and even in rural areas. So what is the challenge? Dr. Ibrahim mentioned earlier on the challenges that are being faced with accessing these devices. So, you know, for us to attain the Sustainable Development Goal 3, which is ending preventable maternal mortalities and every newborn action plan target, we need devices to be able to do this. So I think part of what Dr. Ibrahim mentioned was, you know, having to use the point-of-care ultrasound when there's an emergency without having to look at, you know, your empirical experience, your experience in the field, just looking at what is happening to the patient at the time. Now, one of the challenges is accessibility to high-quality devices, which is a big challenge because as gynecologists, obs and gynecologists, one of the main issues you would have is to find an equipment that you know is of high quality that will give you the result you want. The second thing is affordability. So when you know an equipment is of high quality, it gives you all the measurements you're looking at. How affordable is it? Then the third one is lack of trained personnel. Dr. Ibrahim mentioned this clearly. I'm just doing this a bit of a summary. So how many doctors, I know gynecologists are trained on using ultrasound, but how many doctors can actually, you know, do ultrasound on the patient? If there's need for referral, do referral at the right time. Then maintenance. which is also a big concern, because if you look at the challenge with the economics now, you don't want to buy an equipment that after a year, after 2 years, you are now having to leave it to start looking for a new one. So we're looking at sustainability. So what is Hatch doing? So Hatch, we've gotten a funding from Bill and Melinda Gates to see how we can address those pain points and scale the use of these devices. So if I go back to the challenges, you would see that on accessibility, one of the key things we do is to source high quality devices. So for point of care ultrasound, one of the devices we're looking at for point of care ultrasound are, of course, of best quality. We're looking at GE point of care ultrasound, Philips point of care ultrasound, Butterfly, and Mindray, where you are sure that all the measurements you are getting is of high quality and you are able to make informed decisions. Then we're also looking at affordability aspect of it. So as Hatch, we have funding. One, we're able to pool purchase. We're in about 7 countries. We're able to pool purchase, and that pool purchase gives us some buying power with the manufacturer. So we're able to drive the price down from that angle. Then the other aspect to it is that the funders have given us some amounts of money to be able to give discounts so that this equipment gets to the clinicians at far more affordable rates than they would have gotten it if they went straight to the manufacturers. Then we are investing heavily in training, and that is one of the things we want to partner with Sogon, with leadership. We'll take up the conversation from there. We want to see how we are able to upscale the use of ultrasound to improve outcomes of maternal outcomes. And then for maintenance, we want to see how we get devices that will have long warranty periods, and then also we'll get local distributors that will have engineers that can support whenever there is need, so that you don't need to be waiting for months and the equipment downtime is reduced. So, like I mentioned, we have funding from Bill and Melinda Gates to distribute. It's actually a project, and it's for 3 years. It started in July. So to distribute 980 point of care ultrasound. So part of this will be deployed. It's going to be, we're yet to determine the quantity. We're yet to agree on the quantity, but part of this will be distributed free of charge to some hospitals. But the other part will be on discounts. So this gives you an opportunity to access this particular product at more discounted prices, and with that, you are able to, take care of your patients better and get better results as at when it's needed. Thank you very much to Sogon, and thank you for listening. I don't know if there are questions.
Thank you very much, sir. I'm sure a lot of people are interested on how to get this free ultrasound. Free, you are going to pay. We'll just take 2 questions. No questions. Yes, please, that's the only question we have. Please, Professor Jagun, your question, sir. The mic is behind you.
Thank you very much. How can an institution key into this program? Thank you.
Okay, so there are 2 ways to it. I think the first one, and the easiest one, is we have local distributors who can partner with, for the deployment, we have local distributors who can partner, who we can connect, you can reach out to. Then the other aspect is the deployment. So since we are not sure of the quantities, we need to align with Sogon leadership on the distribution. But for the training, we want to train as much doctors as possible. I think by the time we're aligned on the facilities we're deploying to, then it will be easy to discuss on which institutions we'll key into from the deployment angle. That's from the free deployment angle. But from the commercial angle, we have a booth just across the hall there. You can just come there and meet us. We'll take your contact and we'll reach out to you on when these devices will be available. Thank you.
Thank you very much. Thank you so much for your presentations, Heart Technologies. Apologies again for having to cut your time. So we're going to take now the Woman 2 trial, tranexamic acid to reduce bleeding after childbirth in women with moderate and severe anemia. Speaker is going to be Professor Oladapo Olayemi, who is a professor and honorary consultant at the University College Hospital Ibadan and the principal investigator for the Woman trial. The chairman of this occasion is Professor Brown Adima. I don't know if he's still around, but he's okay. I'm told that Professor Etim Ekanem will be the chair of this session. Is Professor Ekanem around, please? Please, can you come on stage? And the rapporteur is going to be Dr. Eni Tifon Akpan. Are you here? Chairman, sir, it's a 45 minutes presentation, but we have appealed to them to give us a 35 minutes presentation. I know my Oga can do it very fast. I know you paid a lot for this session, but so we can entertain some questions. Page 37. So, hand over to Chairman to start.
Thank you very much. We are now on the page 37. We are going to talk about the woman trial. The presenter is already there. For the want of time, we'll go straight to the presentation. Please, can you go straight to the presentation now? What of these other presentations? Which other is only this one?
Good morning, afternoon, everybody. Thank you, Sogon, for this opportunity. I'll be presenting this on behalf of the collaborators. Incidentally, I wasn't part of the PIs. I was just a national coordinator, so I didn't have any hands-on experience with this trial. I'll recognize Dr. Owa. Please stand up. He was one of our greatest recruiters at the trial. Okay. So, in this session, I'd like to talk about I want to provide a context to the result that will be presented. I'll present the result of the Woman 2 trial, and then we did an individual patient meta-analysis of all trials that have been done, including Woman trial and Woman 2. So I'll be presenting this result too, and then I'll present the implications for practice, and I will have discussions on that because I'm sure if I present this well, you'll have a lot of questions to ask. So these are the two publications I'll be presenting. Incidentally, they were published at the same time, this October 26th in Lancet. So these two papers were published together, and they seem to be speaking in different directions, but we'll be hearing that from us. I must acknowledge this gentleman, Professor Bukola Fawoli. He was the one that inspired this project because his statement that women are different is what inspired the funders to have this trial in Nigeria. And truly, our women are different. By the time we present this, you realize that we're different. So, I'll be talking about the context of the results. I need to mention that this started from woman trial, which we did in around 2010, and we discovered that early use of tranexamic acid within 3 hours of birth was the most useful time by which you can prevent hemorrhage. If you look at the total picture of this trial, we had anemia all over the world, and we believe that women with PPH, with anemia suffer more from PPH, which was the major thrust of this trial. The woman trial had provided evidence that it worked for treatment. What we're trying to do now, which we're still trying to do in another trial we're doing right now, is to see whether it's useful for prevention. The evidence we have of tranexamic acid is for treatment, not for prevention yet. But this was one of the reasons why the Woman 2 trial was done. So, from the Woman trial, you can see that if you give tranexamic acid within 3 hours, you save about 70% of the women. If you give it later than that, it's really not effective. So, Women 2. What was the inclusion criteria? Which women did you want? One women with moderate or severe anemia, and that is less than 10 grams per DL of hemoglobin, or less than PCV of 30%. They will develop vaginally, and then the clinicians will be certain that TXA is not harmful to them, or that they don't need TXA. So if they need TXA, you know they need it already. Tranexamic acid, you don't include them. If you know it will be harmful to them, you don't include them. So these are the kind of women we wanted, and there are other criteria written there. So, we had women, they were triaged into, they were distributed into 2 different arms. Those who would get tranexamic acid and matching placebo, they were all blinded, so nobody knew what anybody was getting. And we had 99% follow-up. This is very important, because when I'm talking about the results, we had to look around and see whether, did we have a problem with our study, or is this result what it really is? And looking at everything, all the parameters, this was a very good quality study. 99.9% follow-up was quite great. So these are all the consort diagram, and we can see that we had very few, if any, people dropping out of the trial. So, Nigeria's contribution, we started very late in Nigeria. We had a lot of regulatory delays. So we only recruited 1,326. Unlike Women trial, where we recruited about 15,000 from Nigeria. This was a very low output from Nigeria in this trial. And these are the centers we had here. Ilorin General Hospital led the way. Mother and Child Hospital, where Dr. Wawok was the next, and a lot of other hospitals there. Now, we couldn't use as many centers that we wanted to use, because unlike what we believe, anemia was not as common as we found. We screened a lot of centers, and we didn't find anemia. Professor Boy is checking his head, because I'm sure we screened the center too. We didn't find enough anemia. So these are the places where we found anemia, and that's where we did the trial. Just to look at the other people who were involved, Adeoyo, Aremu, Dr. Aremu, Oladipo, Dr. Muchola Bijibara from Ilorin, and a few other people, Adeyemi, Professor Adeyemi in Lautech, Dr. Lofremi, Usman Hospital, we had Dr. Imam Usman, Dr. Yewale Aremu at Oyo, and Irian Nikon, and then of course, the central team is written there, myself, Professor Nike, and G.D. Okwade. So, what is the result we found? Baseline characteristics, apart from the distribution from the countries, if you look below that I have highlighted, you can see that the age is the same. The age distribution is the same. 5.6, 6.2, everything is about matched. So we had good randomization, we had good blinding. When we look at the women too in terms of anemia and body mass index, you can see that the experience is about the same. Moderate anemia was about 86% in the 2 arms, and severe anemia was about 13% in the 2 arms. There was no much differences in these values. Then we looked at pregnancy, whether they had, this is about their age, parity, and whether they had APA during pregnancy. APH is important. Please note that we're talking about that a bit because it became very important in this trial. Okay. Placental abnormality, the display was about the same in the two arms of the trial. All the other conditions, hypertension, preeclampsia, eclampsia, you can see that there are very little differences in the distribution. So this showed that we had very good. About labor events, also the same. Induction, oxytocin use, augmentation, everything was about, and this is what we found. In all of these outcomes, the worse the anemia, the worse the condition. So if you are tending towards 5 grams per DL, which would be like 15% PCV, your PPH is about 20%. As you get to like about 9 grams, which is about 30% PCV, about double that, your outcomes are about four times less than if you have, for those who have low PCVs. The same for antepartum hemorrhage, the same thing for stillbirths. So it's obvious to us that anemia is a very important aspect of our perinatal outcome in maternal anemia, that is, in this trial. And it's even worse. If you had anemia to any risk factor, it becomes exponentially more, the outcome becomes worse exponentially. These are the two graphs. You can see the red is if you have anemia or severe anemia or moderate anemia. When you add other outcomes to it, like PPH, previous APH or previous PPH, it even gets it's a multiplier effect. So no matter how bad it is, if you had anemia to it, it gets worse. Now, the part I highlighted there is about antepartum hemorrhage. As you can see, generally speaking, how did our trial go? What was it? Did tranexamic acid, did it reduce PPH in women who have anemia? No, it didn't, apparently. And it looks like it is harmful for women who had antepartum hemorrhage. So this is what we found in this trial. And it means that, well, we didn't get what we thought we got, but we had other information that will be used for clinical practice and implications later. So, finally, I want to present the individual meta-analysis. A bit of context to that. While we were doing the Woman 2 trial, it occurred to us that we've done a lot of woman trials. Maybe we should look at all these patients. So usually when you do meta-analysis, you take the studied results. In this case, we asked for the individual patient data. It was like you're doing the study yourself. So you got all the data, I analyzed it. So all we have is an individual data meta-analysis. And this is what we found with that data. You can see that, now the outcome they used, when you want to do a randomized study, you are not allowed to change the game in the game in the middle of the rules in the middle of the game. You have published your protocol, so if you didn't put any outcome there, you cannot use that outcome in your paper, this is why we are stranded, which is why we did this other one, because we knew that the outcome of life-threatening bleeding was something we didn't put before. But while we're doing the study, it occurs to us. So we now look at all other studies, not only woman trials, some other studies, there's TRAP 2, to see whether life-threatening hemorrhage is something that tranexamic acid can prevent. And that is what we found. So despite the fact that it doesn't seem to work with antepartum hemorrhage especially, it didn't make much difference with anemia, it definitely makes a difference with life-threatening hemorrhage. So how do we put that together? So our recommendation following that is that anemia is a strong risk factor for life-threatening bleeding after birth. We must prevent and treat anemia in women of childbearing age. We think no woman should be allowed to get into labor or deliver with anemia, if possible. And then there's strong evidence that TXA reduces life-threatening hemorrhage. So in women that have risk of life-threatening hemorrhage should get the TXA. This to remind us of how we rush into theater where women are bleeding. This was taken from Pakistan. And so thank you very much. I'm willing to take questions now.
Yeah. Thank you very much for that presentation. Well elaborate and short and to time. So let the rapporteur summarize.
Thank you very much for the presentation. Just for clarification, what is the duration of the study? And has it been completed or it's still ongoing? And then I'm looking at the centers in Nigeria. They all seem to be urban centers. And we know anemia is common in the rural areas. I don't know whether it's the design of the study that it should be in the urban centers, or maybe you can say something about that. And then when you talked about the effect of tranexamic acid on antepartum hemorrhage, is it any type of APH, or is it divided into effect on placenta previa or abruptio placenta? It's not quite clear. It will be, if you can explain that, please. Thank you very much.
Next question. Let's take all the questions at once so that they can attend to them effectively. Any other question? Okay, you can go ahead.
So thank you, Prof. The study was about for 3 years. And like I said earlier on, we actually screened for anemia in both rural and urban areas. And we used we started by leveraging on the 50 hospitals used for woman trial. We screened every single one of them. And it was in this site that I mentioned that we had anemia, sufficient for the trial to be taking place in Nigeria. That's number one. Then, why are these sites, so it wasn't like, we didn't have a design to pick urban or rural sites. We actually used Kano. Kano was one of the sites we used. Am I right, Toyin? Yeah, but they dropped out due to technical reasons. The records keeping was not sufficient for the quality of the trial, and they had to drop out. And then APH, yes, this is what we think. All APHs are, it doesn't work for, tranexamic acid is not good for all APHs. And the reason is this: there are two phases of DIC, the fibrinolytic phase and the other phase. I think that's the consumptive phase. So, tranexamic acid works in the fibrinolytic phase, and that's the earliest phase of PPH, of APH rather, of PPH or APH, any bleeding. So, if you are able to catch them at that point in time, we think it can work. But unfortunately, people with APH will have bled before they came. That 3 hours will have expired. So by the time they are coming to us and having PPH following APH, they're in the other phase of DIC, and that doesn't work for them. So that is the explanation we have for this. And if you get to the article, you will see all. I can't give all the details, but the article gives all these details. In our discussion, we discussed all these issues about APH being not responsive to tranexamic acid, and making PPH following APH not being responsive to tranexamic acid. I hope I answered the question. Thank you very much.
Yeah, thank you. Can we give him a applause? Thank you very much for good presentation. I think we are done. Thank you.
Thank you very much, Woman Trial, for helping us save time.
Sorry?
Okay. Bridge Clinic, are you set? Bridge Clinic, we're going to move like a truck now. Bridge Clinic, please, you have 7 minutes. I understand your flight has been moved forward. 7 minutes, please. 7 minutes. The time is going. While we're waiting, let's have Skyline, Nature, get ready. Med Height Pharmacy, get ready. Alpha Pharmacy, get ready. Solina, get ready. DCL Labs, get ready. Unimedical, get ready. Field Technology, get ready. And UnoSource, I thought we took that yesterday. Get ready. We took that yesterday. We took that yesterday. Bridge Clinic?
Yes.
7 minutes, please.
So I'll just wait once they put up the slides. Good morning, everyone. Thank you very much for giving us this opportunity. My name is Dr. Ogunero. So I want us to go with the presentation. Can we have the slides up, please? Our time is going. Bridge Clinic. All right, I'll just start. All right. So Bridge Clinic, I'm sure a lot of us know about Bridge Clinic. It's been here for 25 years, and majorly we're a fertility clinic. But what we're looking at to offer is the option of what we call transport IVF. We know that infertility is on the rise, generally in the world and even in Nigeria here. And the cost of managing clients is really on the rise. A lot of patients cannot afford this. And even setting up in your own private sector as a gynecologist in different private sectors and also the public sector sometimes can be a very, very huge cost considering the inflation rate and everything. So we're looking to offer the option of partnership, which is for the option of transport IVF. We know that the situation presently, about 3 in 10 couples in Nigeria have issue with infertility, and this is also on the rise. We know a lot of factors are affecting male factor, female factor infertility, and also the option of the effect of ASAS genotype incompatibility, which talks about genetic testing. So we're offering this partnership. And what is really about transport IVF? What it just involves is the process where retrieved oocytes are collected, all right, and they are transported to a facility where we can have these oocytes injected. So the opportunity we have is for gynecologists that don't have a lab, you don't have a clinic to set up. You can manage your patients, stimulate them, all right, and we have the eggs collected using a transporter. That was one of the slides I showed there. We have transporter that will transport the eggs to our facility. They are injected in our facility. You can have the culture in our facility, and you yourself, you can even come and do your egg collection, come back and have your embryo transfer. So you are the one that bills your client, all right, and they come in for their treatment processes. And of course, the objective is, of course, we want to build capacity. I want to provide highly assisted conception services, high quality, and this also helps us to reduce the cost of setting up. Instead of having your own lab, I will know that it's quite expensive. The issue of power in our sector, where you don't have to run generator 24 hours of the day. You can have your culture, you have your own patients. Some people, even when you refer them, they prefer to still go back to their doctor. All right, so you have opportunity of seeing your own patient, stimulating them, but the culture and the egg collection and the transfers can be done at our facility. All right. We also have opportunities of training personnel, all right, to just make sure that we are setting up your lab to have the ISO accreditation. Of course, in return, the access to our transport IVF network, there's training for both your doctors and your nurses and even your embryologists, if that is also available. And of course, it gives additional texture to your own brand. It's not just about you having your hospital. We know we've talked about maternal and child health, but there are a lot of people that don't have this opportunity to even have a child. They're just praying to have just one child. If they can have that child, they'll praise God all their life. All right, so that opportunity is there for you to use at the Bridge Clinic. I'll just run over the slides again. Of course, reduce cost for your IVF cycles. So we know that the average cost of IVF is really very, very high. So if you have the opportunity of just billing your own patients, all we offer is a partnership where we have an SLA agreement, and you just have a sign-up fee, and per cycle you have a charge given to you, and of course you can charge your patients as the case may be. All right. Other opportunities that we have is cryopreservation. We know that we've talked about prevention of gynecological cancers, CS, cervix, breast cancer, and the likes, as the case may be. So we know the option of cryopreservation is also available for a lot of patients, and we know a lot of patients that are going through cancer treatments. For the men that have to freeze their semen before they go for their cancer treatment, and even for the women also that really want to go for surgeries, and even chemotherapy, we know that affects the reproductive cells, so they can have opportunity of freezing their gametes and come in for future use. All right. The final thing I'll just talk about is genetic testing. We have some pictures that will show our labs and what we have in our laboratory. Now, we also know the issue of ASAS, genotype incompatibility, and also the issue of chromosomal disorders, Down syndrome, as the case may be. So the opportunity of doing what we call pre-implantation genetic testing. We already know the availability of prenatal diagnosis where the woman is already pregnant. But if you have the opportunity of testing the embryos before you have them transferred, then you can test the embryos and determine what exactly is the makeup and genetic makeup of this embryo. Is it AS? Is it SS? And you can transfer genetically abnormal embryos into the women. I remember a situation of a couple that I managed in the early years when I joined the organization. They had a child that was SS, they were AS, and they were looking at the opportunity of going through pre-implantation genetic testing, which they did. Now, the extra advantage that offers is that you can also do what we call HLA matching, which means that the embryos that have been generated, you can know which one will be as a source of bone marrow transplant to the living child that's already suffering from sickle cell anemia. So instead of looking for donors that they are screening up and down, you can have the advantage of testing the embryos to know what HLA match is matched with that child that's already suffering from sickle cell anemia. And that has helped in treatment over the number of years. So we've had partnerships with clinics all over Nigeria. We have branches in Abuja, we have in Lagos, we have in Port Harcourt, and we also have in London. So it means that if we are in any of these zones, for the South-South zone that we are here, we have the business manager for Port Harcourt here. We also have for Abuja for the Northern zone, and for Lagos for the Southwestern zone. And of course, some of us that have branches outside the country, we know we have representative from London here. We have Bridge Clinic London. And as I said, we have some firsts that we've done at the Bridge Clinic. We're the first clinic that achieved conception via ICSI in Nigeria. Also the first conception via surgically collected sperm. For before now, people that had azoospermia would rely on donor sperm. But we know the advent of surgical sperm collection that helped to manage a lot of men that hitherto before now would have been considered not being able to father their children.
Thank you very much, sir.
Thank you, sir.
Thank you so much, sir.
So I don't know if you have any questions. I think I was able to round out with 5 minutes.
One question. They are offering us the opportunity to do IVF in their clinic with our patients. No question.
All right,
thank you very much. Sky Cecil Ken, Nature Fields. 3 minutes.
Good morning, everybody here present. I am Otaka Agwemano Chinedum, B.Pharm, M.Pharm, PhD. I am here representing Silken Limited, Nature's Field. I have 3 minutes to make this presentation, so I quickly go and hit the point. This is a gathering of gynecologists and obstetricians, and I know very much that you are very much involved with patients, with women who are pregnant, and often anemia comes up. It's a recurrent decimal, and WHO says that a pregnant woman must take between 30 to 60 milligrams of iron daily, and often the food we eat, our staple food is often carbohydrate based. In the morning, she takes tea and bread. In the afternoon, she takes gari or rice. And often, the kind of rice we even eat is the white one, the one that the bran is already off. So a lot of sources of the micronutrients that the pregnant woman needs are lost. That is why from the stables of Nature's Field, we brought a unique formula that is called Pregmom. Pregmom has about 28 milligrams. It has 28 milligrams of iron as iron fumarate, and has between 800 micrograms of folic acid. So we know very well that these two micro ingredients or micronutrients are the basic things every gynecologist look out for any supplement that he or she wishes to use to support the woman. Now we didn't just stop there. In the course of our work, we found out that doctors are saying that the quantity of iron in Pregmom is not up to what they need, and we came up with another one we call Folibin. Folibin has 53.25 milligrams of iron. In other words, we have about 155 milligrams of iron fumarate, and the equivalent is it's 53.25 milligrams of iron that the pregnant woman is taking daily. For folic acid, we have 750 micrograms of folic acid in Folibin. We are not only concerned about women reproductive health, we also look at the men reproductive health. That is why we have a unique brand here that is called Adam Desire. Yes. It's a unique formulation. It's a unique formulation that has helped a lot of men to also perform, boost their libido, and also ensure stamina.
How much is the Adam's Desire?
Thank you very much. A pack of Adam's Desire is just 8,000 naira. For the pack that is by 15, that is packed by 15 vegetable capsules.
So that's for a month.
Then we have the box of 30. The box of 30 is about 16,000 naira. And the good thing is that these brands are made in the US under an FDA certified machinery and obeying all current good manufacturing practices, just to make sure that we come up with a blend that has been therapeutically titrated to meet both the need of the man and the need of the woman. We are not just there. We didn't just stop there. We have looked beyond. What happens when the woman puts to bed? We've even formulated another form of pregmom we call pregmom breastfeeding that is fortified with enough calcium to make sure that the woman has enough strength to take care of both the little baby and the big baby.
Thank you very much. Your 5 minutes are done. Actually,
thank you very much. And I hope to see you at our stand outside there. We have all these products on display. Thank you very much, and God bless.
Please join them on their stands. I can guarantee you that these products are good. Now, Med Heights Pharmacy. Are you here? I know you almost gave me a blow a few minutes ago when I said I'd cut your presentation. So, 7 minutes, please go ahead. We agreed on that.
All right. The pointer, please. Is this a pointer? Yes. Okay, good morning, everyone. Good afternoon. My name is Jessica from Med Heights Pharmacy Limited. Today, I want to talk about the role of maternal nutrition in pregnancy outcome. So WHO in 2023 brought out a report that 20% of maternal mortality was as a result of inadequate nutrition and even iron deficiency. So if something as preventable as this can affect that food plays a major role in helping with fertility. For example, folate is essential for healthy eggs. Selenium, vitamin C, vitamin E, they play a role in having antioxidant properties. And a study I read came across showed that lower total antioxidant status was found in women with PCOS. This means that a nutrition that is rich in antioxidants can actually help ameliorate or ease the symptoms of PCOS. In this next slide, let's quickly look at periconception nutrition. Periconception is that period from 14 weeks before conception and 10 weeks after conception has happened. And this period is very important because the activities, the lifestyle of the mother or the father, but we're talking about the mother in this case, the lifestyle of the mother can affect the outcome of the pregnancy. So her diet, whether she's smoking, drinking, things like that can affect the outcome of the pregnancy. You would find cases where some congenital malformations happen, like neural tube defects, spina bifida. You also see cases like cleft lip palate and all. It can actually be prevented if the lifestyle of the mother is well taken care of in this sensitive period. Now let's look at neural tube defect, which is one of the effects when there is deficiency in folic acid. WHO standard for supplementation of folic acid is 400 micrograms daily for any woman who is preparing for conception. Another study I came across showed that folic acid supplementation alone may not be sufficient in preventing the reoccurrence of neural tube defect. There was a study carried out by Stephen in 2021, and he found that cultured rodent embryos that had inositol deficiency actually were resistant to, were unresponsive to solid folate supplementation and had cranial neural tube defect. So it means that inositol, in addition to folic acid, can help fortify and reduce the chances of neural tube defect. This is a picture of neural tube defect. It can actually be avoided, and just as little as folic acid supplementation, 400 micrograms, and probably higher for women who have experienced it with their children before, is very important in preventing something like this. Okay, so still speaking on inositol, inositol is something that is found abundantly in nature. But this particular inositol, the myo-inositol here, it actually helps with insulin sensitivity. This is very important because it can actually help reduce the symptoms of PCOS. Remember, when there is insulin resistance, it can build a flare-up of the androgen hormones that cause a form of hormonal imbalance. So inositol can also reduce gestational diabetes. It helps to improve ovulation. It helps to balance the hormones. Another element we can look at is the coenzyme Q10. What role does coenzyme Q10 play in fertility? Coenzyme Q10 is actually found abundantly in the human body, but as we age, the amount of coenzyme Q10 in the body starts to decline. So it is important that a woman fortifies herself with coenzyme Q10 because it plays a role in reducing oxidative stress. Thank you. It plays a role in reducing oxidative stress, which can cause a form of a decline in fertility. And then it also improves ovulation, improves age-related fertility. Another thing we can look at is N-acetylcysteine. N-acetylcysteine also helps to regulate ovulation, it improves insulin resistance, and it also restores hormonal balance. Another thing that N-acetylcysteine does is it thins the cervical mucus. So it's even very good for women who have been on contraceptives and are trying to reverse the effect of the contraceptives. N-acetylcysteine also has anti-inflammatory properties. Now, many women, when they enter pregnancy, they already have nutritional deficiencies, and this can be avoided if they start taking the preconception seriously, even before pregnancy occurs. And this brings us to what our supplements can do, which is Pregnatab. Pregnatab comes in two major forms. We have Pregnatab Original and Pregnatab Conception. Pregnatab Conception contains active ingredients like inositol, N-acetylcysteine, coenzyme Q10, as well as 18 other micronutrients. And this actually helps to improve the chances of fertility happening. And then we have Pregnatab. Pregnatab Conception also contains 400 micrograms of folic acid. Now, when a woman successfully gets pregnant, she can switch over to Pregnatab Original. Pregnatab Original has 27 milligrams of iron, 600 micrograms of folic acid, as well as 17 other micronutrients. So with Pregnatab, we can actually change the statistics and reduce the rate of maternal mortality. Thank you.
Much. Thank you for keeping to time. Thank you very much. You can always visit our stand and pick up. Alpha Pharmacy, are you here? Alpha Pharmacy? No? Please go ahead. You have 7 minutes, please. We're going to talk about current. Anyway, tell us what you're going to talk about. Go ahead. Current trends towards providing quality solutions for improved clinical outcome in maternal and child health. Mrs. Joyce Emerenini. You're not ready. Solina, please. Get ready. I understand you have two presentations. Is Solina here? Please get ready. Alpha, please go ahead.
Okay. Thank you. Good afternoon, professors, consultants, and other healthcare professionals here present. Permit me to stand on the existing protocol. My name is Joyce Emerenini, and I'll be making this presentation on behalf of Alpha Pharmacy. Okay, as you know, we are an indigenous pharmaceutical company. We are renowned for the provision of rare ethical drugs and devices. And we've partnered caregivers for about 39 years now. Okay, so we'll be talking about the management of recurrent miscarriage and preterm birth in conjunction with the UK NICE guidelines. And then we'll also discuss your choice of progesterone, because that is what the UK NICE guidelines actually talks about. Okay, so we all know what miscarriage is. About 10 to 20% of pregnancies will end in miscarriage, and then recurrent miscarriage can be very, very challenging for both the patient and even the clinician. There are several factors which we already know. I'll just run through the slide because of time. And then for preterm birth, it is actually, according to WHO, is actually the leading cause of perinatal morbidity and death. And then in Nigeria, preterm babies will actually account, the death of preterm babies will actually account for about 40 to 16% of perinatal deaths. We'll talk about the importance of progesterone in luteal phase support or in luteal phase in pregnancy. It was found out that the removal of the corpus luteum at about 7 weeks of pregnancy actually led to the reduction of serum progesterone, and then consequently there was bleeding and miscarriage. Okay, so the role of progesterone is what we already know in pregnancy. It stimulates the growth of blood vessels, prepares the uterine for the implantation of the embryo, stimulates the endometrium, and all of that we already know. Okay, so according to the UK NICE guidelines, progesterone should actually be offered to prevent threatened miscarriage and also preterm birth. If you look up the guidelines, you see that in section 1.52 said you should offer micronized vaginal progesterone 400 milligrams twice daily to women with an interuterine pregnancy confirmed by a scan, who have also actually had previous miscarriage. And then if the fetal heartbeat is also failed, you can continue until about 16 weeks. That's for the prevention of, or for the management of threatened miscarriage. Then for preterm birth, said offer prophylactic vaginal progesterone for women who have either a history of spontaneous preterm birth before, and then also you also look at if the transvaginal scan, the cervical length is about or is less than 25 mm, you should also offer prophylactic micronized vaginal progesterone to the patient. And when using vaginal progesterone, you start treatment from about between 16 and 24 weeks, and you can continue till about 34 weeks. That is for the prevention of preterm birth for patients who have had preterm birth previously. This is the study that was carried out that actually precipitated what NICE actually said should be done. Okay, so when you look at progesterone, the first thing you want to think about is you think about the luteal phase support, but we are also talking about threatened miscarriage and then preterm birth. So when you want to choose the progesterone to use, either for luteal phase support, for the prevention of recurrent miscarriage, or for the prevention of preterm birth, you should be looking at the source of your progesterone. Is it a natural progesterone? What is the cost? The source? Is it synthetic? Where is it gotten from? You also look at the molecule. Is it bioidentical with what you have as produced by the corpus luteum and the placenta? And then what is the route of administration? Is it targeted at the endometrium, where the progesterone is actually needed, or it is found in large quantities in blood and it doesn't get to the target organ? So you look at also the concentration in plasma and also the concentration in the endometrium itself. And then you also look at the safety because there are actually studies that have shown that synthetic progesterone is not actually very safe for both the mother and the baby. So there are several preparations of progesterone which we already know. The tablets are them.
You have 1 minute left, please. 1 minute left, please.
We know that the tablets, as it is, do not survive the first pass effect, and then the metabolites are actually harmful to the mother and the baby. And then they have also shown systemic side effects. And if you look at countries like the UK, Australia, and Canada, the synthetic progestins are not allowed to be used, or they are not even in use, especially in pregnancies. And that's a study that was carried out to show the defects when using synthetic progestins. Okay, so you look at the injection, they are actually, the patient do not comply and all of that. You look at some vaginal pessaries, they are only used vaginally. Some of them come as capsules, which do not really dissolve. Sometimes, you know, there was a case that someone had to do an evacuation after a miscarriage and found out that the several capsules that were given to the woman as progesterone were actually very intact and, you know, came out. And then so we are actually talking about a product that you already know, just to reaffirm to you that Cyclogest is the way to go. Cyclogest is natural progesterone gotten from a species of Mexican yam. It is bioidentical with the endogenous progesterone as produced by the corpus luteum and the placenta. It has the same molecular structure with the endogenous progesterone as produced by the corpus luteum. Cyclogest actually avoids the first pass effect by, you know, being targeted. It is delivered at the endometrium where it is actually needed, and it has scientific proof. There are several studies. In fact, any study that you find that micronized vaginal progesterone was actually used, the product is actually Cyclogest that was used in those studies.
Thank you very much, ma'am. I actually gave you your 10 minutes.
Okay,
thank you.
Thank you very much.
Solina,
if there are questions, we are at the stand.
any question
you can actually come
for them?
and we can take your questions. Thank you.
Solina, are you ready? Solina? I understand you have 2 presentations. I appeal to you to try and get straight to the point because we are trying to wrap up as fast as we can. So go ahead.
Okay. Good afternoon, everyone. My name is Dr. Chinedu Obikili. I'm from Solina Center for International Development and Research. So I'm here presenting Optimizing Uterotonic Therapy, Heat-Stable Carbetocins Clinical and Economic Benefits. The rationale behind this presentation is looking at the conference theme of sustaining maternal health care in a challenging economy. We realize that as obstetricians, we have to start to think about the total economic costs of whatever decisions we are making. And so we don't just look at the drug itself, but we look at other things around it that add to the overall cost of care. So there are 3 goals of this presentation. One is to assess or to present the clinical evidence of carbetocin's efficacy as compared to other alternatives. The second is to discuss the cost-effectiveness analysis of carbetocin as compared to its alternatives as well. And then the third is to identify potential research gaps within carbetocin. Because the first thing that we understand that some people still have some degree of doubt about how well carbetocin actually works. So I would skip through this because we've discussed a lot during this conference about postpartum hemorrhage. We are aware of the impact of maternal mortality. 1 in 4 women who die in the world globally die within Nigeria. And whenever I look at the statistics for Nigeria's maternal mortality, it always, you know, leaves me in some degree of heartbreak because we have so many wonderful obstetricians, and yet we have statistics that is close to war-torn countries. So the first thing, just to talk about what we know, WHO's recommendation, which is that oxytocin still remains the first line of treatment for prevention of postpartum hemorrhage. However, in cases where quality assurance cannot be guaranteed, the WHO recommendation is that carbetocin should be used. And the question we need to answer is that in Nigeria, can we guarantee the quality of oxytocin that we use? Now, some of the trials that were done, there's the Champion trial and Cochrane systematic review. I think a lot of us know about that, so I'll not dwell so much in that regard. So, looking at the mechanism of action, I'm not going to delay so long here as well because we know that we are pressed for time. But the essence is that we know that oxytocin has a short duration of action, while carbetocin and ergometrin gives a sustained contraction. And it's important in understanding this mechanical differences because that's why carbetocin cannot be used for induction of labor and even currently is not being used for treatment. It can only be used for prevention at this time. So the comparison that we did basically is looking at we just brought out the three major ones that we commonly use: oxytocin plus misoprostol, and carbetocin. And we looked at them under different dimensions, under maternal deaths, postpartum hemorrhage greater than 100 mils, postpartum hemorrhage greater than 500 mils, blood transfusion, ICU admission, and the need for use of additional uterotonics. Because when we give oxytocin, it's not just one ampoule of oxytocin. Typically, if there is postpartum hemorrhage, you might still need to give misoprostol. Sometimes they put oxytocin inside the infusion, and all those things add to the eventual cost of care for managing that woman. So it's important that we consider not just the price of an ampoule, but the overall cost of care for the woman. So when we looked at these different outcomes, what we found as a summary is that carbetocin is superior to oxytocin as a standalone, but it is similar to oxytocin plus misoprostol. So there was no superiority of carbetocin to the combination that we commonly use of oxytocin plus misoprostol. The next thing we looked at is the side effect profile. Because you know that misoprostol typically sometimes they have chills, sometimes they have fever, sometimes there are complications that need to be managed. And when we look at the side effect profile, you can see that carbetocin alone is superior to oxytocin plus misoprostol. And by the time we give sometimes paracetamol, sometimes you have to cover the woman. There are lots of manpower requirements to handle those complications, and that also has a cost of care overall. So the side effects we looked at were nausea, vomiting, headache, abdominal pain, hypertension, shivering, fever, and diarrhea. All the slides are available, and then at the booth you can also always answer any questions. But for the sake of time, I'll not go into the details. But the summary is that oxytocin plus misoprostol had a lot more complications. Now, when we looked at this efficacy, the second thing that we also consider is now the quality assurance in our environment. And studies that have been done showed that 74% of oxytocin in our environment did not scale the quality test. That means, and that's why, even though the recommendation is to give oxytocin at the time of birth, sometimes we add misoprostol, but commonly sometimes we still put in the infusion, we say it's not working, we double dose because we are aware that a lot of the time the drug that we're giving might not even have the complete medication, the complete content that is required. For misoprostol, we had just 33% that failed the quality test. So a lot of our oxytocin in our environment fails the quality test. And most of the reason for that is that maintaining a cold chain, not only is it expensive, but we lose the potential of the drug along the line, from importation to transporting it to the facility, to having a fridge, having 24 hours power supply. Sometimes we even just keep it in the labor ward tray for days. And the effectiveness of the oxytocin is definitely going to go down. So we just looked at some implementation research that has been done. I will skip through that, but please, if anyone has any questions or information, we're at the back there. Now, one of the very important things is about cost, because the common thing people have been saying for the longest time is that, oh, it's expensive, it's too expensive. But now, there was a deal with WHO and Ferring Pharmaceutical. So carbetocin is currently given at 30 cents. And by the time we look at the cost of bringing it to Nigeria, it goes up to about 75 cents. So currently, public access price of carbetocin is about 1,450 naira. No longer as expensive as the Pabal that was 15,000 naira, even when our naira still had value. This 1,004 is even because of the current value of the naira. As at last year, it was about 400 and something naira for an ampoule of carbetocin. And I'm aware that a lot of people don't really know, are not aware that carbetocin is now a lot more affordable. So this just looks at cost-effective analysis. The green colors just show where it is. You can see that carbetocin is found to be more cost-effective. Unfortunately, we have so little time, so I cannot go into as much detail as I would have loved to. But when it comes to the cost-effectiveness, we found that this was done in 2022, that the total cost to the woman is about 19,138 naira as compared to oxytocin or oxytocin plus misoprostol, which is about 19,998 naira. So there's a difference of 860 naira. And this looks at personnel cost, hospital stay, blood transfusion, because if you give oxytocin and she bleeds, you transfuse blood, that also has a cost of care. You give paracetamol, it has a cost of care. You give hydrocortisone, it has a cost of care. So totaling everything, and very importantly, the cold chain, because maintaining a cold chain is also very expensive. So those are part of the issues that make oxytocin very expensive, and that's why even the quality of oxytocin in a lot of our environment is not up to standard. Then this just looks at the
Thank you very much. Thank you very much.
Okay, so I think I'll just go down to the research questions since we have very little time. So the reason for this is almost like a conclusion. The reason why we brought this is that we believe that people should practice evidence-based medicine. And we found that a lot of people are combining carbetocin and misoprostol. And that is not an evidence-based practice, but because of the carryover of oxytocin and misoprostol, people just do that because we know that you don't want to have a woman bleeding for you. And so we feel like we need to generate some degree of research to really find out what exactly can be done. So some of the research questions we have are, does carbetocin plus misoprostol offer an advantage over carbetocin alone? Another research question is, can carbetocin be used for PPH treatment? There's a REACH trial that is currently ongoing. We expect the results to come out around Q4 of 2026. Other questions is, can it be used for treatment after it has already been used for prevention? Then is there room for dose adjustment of carbetocin? We are using 100 microgram, can we use 200 microgram, can we use 50 microgram? Is the effects different or the same? Another one is, does carbetocin's efficacy vary in different groups? Cesarean section, multiple pregnancy, and then also there's a lot of room for implementation research. So the call out basically is to ask that we as obstetricians, focus, also do some research and find out, are there things about this carbetocin that can be different? It's not a specific brand, it's just a general outlook. And then the last question and the final question, which is my last slide, is that now WHO recommendation says that in environments where quality assurance is not guaranteed, carbetocin should be used as first line. So considering the challenge of maintaining cold chain in Nigeria and the cost effectiveness and the benefit or the cost effectiveness of the public access price of carbetocin, should we as obstetricians consider carbetocin as first line for prevention of postpartum hemorrhage? Thank you.
Thank you very much. The second presentation, are you the one taking it?
No.
Okay. Thelma O'Reilly. Improving maternal health outcomes through sustainable financing and innovative digital solutions. DCL Laboratories, please get ready. Unimedical, get ready. Field Technology, get ready. And the CC Trace session, please also get ready. You have 10 minutes. Please go on.
Thank you very much, sir, and good afternoon, everyone. My name is Thelma Oriade, and I will be running us through the FORMON program, specifically around how we are improving maternal health outcomes through sustainable financing and innovative digital solutions. So the FORMON program is financing and operational revitalization for maternal care, and I'll be speaking through our program overview and also the progress that we've made so far. So again, not to dwell on this, we all know about how maternal mortality is a major, burden in our climb, and also how we contribute about 20% to the global death toll. And we also have knowledge and discuss how the 3 delays contribute majorly to these deaths that are recorded. So for the program, we also are tilting towards reducing the maternal mortality that are due to the 1st and the 3rd delays in receiving care. So moving ahead, this is a slide that shows some of the results that were found that links to the delays, that links to the deaths that are recorded in our environment. We see how there are a lot of deliveries taking place at home, as well as lack of equipment, shortage of supplies, also contributing to the total deaths that are recorded. And so, for the form, what we want to do is reduce the maternal mortality, improve the quality of maternal care, and also ultimately strengthen the systems for safer childbirth. And as a program, we are looking to provide finance to 150 public and private health facilities, and we are also doing other interventions like building the capacity of the healthcare workers, digitizing the patient records, and also community engagement. The program is being implemented by 3 organizations, Helium Health, Solina, and Afrida, with funding from MSD for Mothers. So this slide shows the 4 interventions that we are currently implementing. We are providing facilities with finance so that they are able to upgrade the infrastructures, have life-saving commodities, and overall care provided. We are also digitizing the records of these health facilities using the Helium EMR so that they can have a process that is more effective to manage their data. We also build the capacity of the healthcare workers so that they have the skills and knowledge to take care of women visiting the health facilities, and then we are linking the women in the communities to health facilities and incorporating their voices into the care that is being provided. So speaking on our progress so far, currently we have 87 health facilities that are benefiting from our program interventions. And speaking about this, we have 12 that have gone and received benefits of the loan, 69 that have benefiting from the EMR, and then we have 6 that have benefited from the loan and also the EMR. There are a list of eligibility criteria to be able to benefit from the FORMON program, and it varies based on what you want to, what your major interest is. So there's a criteria for joining the program for the loan, there's also the criteria for the EMR, and then finally there's the criteria for the just joining the program in general. So speaking on how we've been able to make some progress with the finance, currently, as we said, we have 18 health facilities that have improved their health facilities using the loan that we have received. And they've done this by 3 of them have expanded their buildings, 12 have procured critical equipment that are required, including the ultrasound scanning machine, theater lamp, ECG machine, and operation table. We have 3 health facilities that have improved their pharmacy by procuring life-saving commodities and medicines that are needed. And on the right, you can see pictures of one of our health facilities that upgraded their operation table. On the top, we have what they used to use before, and now what they procured after they got the loan. To the next bit, we also have made some significant progress with the digitization, where currently we have 75 health facilities that are managing their records efficiently. And we have 16 more that are in the pipeline to finalize their digitization. And of course, we've trained over 1,000 women to effectively utilize the electronic medical records to take care of their service. And for here, we have feedback from some of our beneficiaries where one of our MDs mentioned how they've used paper before now and how it has been cumbersome. And so they really enjoyed the fact that they can now use the electronic record to manage their patients, and that has significantly reduced patient waiting time. On our capacity building, as we mentioned, we've conducted 4 rounds of training for 83 healthcare workers, for 83 health facilities. We've trained a total of 175 healthcare workers on antenatal care. We've also trained them on EMOG, trained them on postnatal care and MPDSR. And for all 175 healthcare workers that we have trained, they are now able to effectively use the pathograph for deliveries. They are also able to manage puerperal sepsis as well as the 3rd stage of labor. They can recognize and also manage eclampsia as well as postpartum hemorrhage. So we have some pictures on the right from our training. Speaking a little bit more still on our capacity building, we can see how for the quality of care improvement, we are leveraging the safe care methodology to improve the care that are provided to women who visit the health facilities. And using this methodology, we've also made significant progress. So for example, 64 health facilities on our program, they now have standardized SOPs that guide their operations. They've also adopted the standard triage systems to sort patients efficiently, and they've also displayed the patient's right charter, which is critical for efficient care. Also, we have 16 health facilities that have well-equipped hand washing stations, which would also help reduce the infection prevention and control. And also, we have 50 health facilities that have quality improvement teams set up. And we have pictures here from how we've been able to facilitate hand washing systems set up in one of our health facilities. And then rounding up now, we also have the committee engagement bit, where over 3,700 women are now knowledgeable on the danger signs of pregnancy. And we've conducted 46 town hall meetings where we are incorporating women's voices into the care that they receive.
Thank you very much.
165 women directly referred to health facilities as well. Now, to round up, we are still enrolling health facilities on our program. So if you are interested, please meet us at the booth. You can also scan the QR code to indicate interest using the form, and we are happy to speak to you more after now. Thank you again.
Thank you very much. Kamita in her stand. DCL Laboratories, are you still around? Because I think you were. DCL Laboratories, I understand you have 2 presentations. Maybe you should come in with your team. Have you given them your slides? You have 2 presentations, 15 minutes each. You're making? Okay, you're taking one now, and you're taking one later. Okay, that's good. So which one are you taking now?
Amnesia.
Sorry? Okay, please go ahead.
Financing on management. They have it. Is it being projected?
Go ahead.
They are not projecting it. Do you have the slides? Okay. So,
Are you not ready? If you are not ready, can we take... Yeah, I told them. Unimedical, field technology. I know CC Trees has loaded their presentation. Dr. Who? Dr. Gideon, which is it? I was just stand the secretary of the LOC. His phone has been stolen or missing. Oh, he lost it yesterday. Please, if you have his information to how this phone can be got, no wonder we're having a lot of hitches. It's an Infinix Hot 5. Last seen in the Ibon Hall yesterday at about 4 p.m. Please, I'm appealing to you, I'm begging you, please come and please return that phone. New technology. Are you ready? Please come. You have 7 minutes. No, 3 minutes. Please, can we move fast? Field technology. CC Trees. Dr. Adaramoye, are you ready? I saw her earlier on. Are you ready? Once CC Trees climbs this stage, or I will move faster. You are... Sorry? Field technology, please, you have 3 minutes, please. You paid for 5 minutes. Okay, take your 5 minutes. Please go ahead. Please move.
Good afternoon. My name is Yewandema Burukoje. I'm a pharmacist. I work with Field Technology. Field Technology is a health tech company. We've been around for a while. I don't know how to use this. Okay, we've been around since 2018. We started with data. We worked with the federal government to build NHLMIS. For those that don't know about NHLMIS, we are in charge of making sure every donation that is being made to the federal government is put in a digital form, and then they can have an overview of how to transport it across Nigeria, across all the healthcare systems. But why are we here today? We are here today because of safe motherhood. That's why we are here today. So we are part of the people that were given the grant to facilitate, supply of the new therapies that we have. So today there's been a lot of talk about, this is not working. There's been a lot of talk about tranexamic acid, calibrated drapes, stable carbitocin, and all of that. So based on that, we have a bundle. We have a bundle that we call the postpartum hemorrhage bundle. It consists of oxytocin, misoprostol, tranexamic acid, stable carbitocin. We have the Solina talked about stable carbitocin, It's not working. Okay. Okay. Thank you. Thank you. So as I was saying, we are joining the war against postpartum hemorrhage by making available all the medications and the products that have been discussed here. We have our bundle, which consists of oxytocin, misoprostol, tranexamic acid, carbetocin at the discounted rate of 1,600 naira per ampoule, and then we have the calibrated drips. Calibrated rates from us, that's what it looks like. It costs from us 1,505 naira. And one of the major benefits from us is that all these products are available either as the bundle or as individual products at the discounted price to you. It will reach the hospitals, federal hospitals, state hospitals, private institutions at the discounted rates for free. So we are going to deliver it to you. Cost of logistics is on us. That's part of what we are using our $11 million US for, to ensure that delivery is free. Technology-wise, you can view your order from beginning to the end. So this is what the drapes look like. We have it available at our stand outside. For the first 10 orders today of 200K, we are giving you a free AccuCheck glucometer, which will come with your order as it's being delivered to your hospital. But there is a caveat. The caveat is that the heat-stable carbetocin for now is only available to the public institutions because of the price, that very low price. It's available there. We are aware that the public institution cannot meet the demand of the society. I mean, I gave birth in a private institution and I had postpartum hemorrhage. Thank God for God and my gynecologist, whom I was hoping to meet here. So I know that the private needs to have that heat-stable carbetocin, but we are working towards that. What we can assure you is that even our oxytocin is at the best cost, and we are able to ensure guaranteed cold chain storage and transportation from our warehouse to your hospital with free of charge logistics. And anybody that buys from us, there's something called cashback. But I won't go into all that details for now. We are just saying that at Field Technology, we have all the products that have been talked about here available for your pharmacy, your hospital.
1 minute more.
Thank you. And we are also willing to collaborate with you in terms of training. So for any institutions or private hospital that wants to train their staff on all the products in the bundle, we are available to collaborate with you to train your staff. So thank you so much.
Thank you very much.
Outside.
Thank you very much.
Yeah. Any questions?
Thank you so much. How much are your drapes? Somebody was asking.
Okay, so the drapes is 1,505 naira. The carbetocin is 1,600.
Thank you very much.
Thank you, sir.
Okay. I didn't see DCL Labs again. I guess they have left. Unimedical, can't find them. CC Tris, are you ready? CC Tris, are you ready? You have 15 minutes. They came here, they were standing here, they came on stage, they left. Okay, they left, they were all there and they left. Okay, so Dr. Adaramoye Olawumi. So just wait. So yes, ZFAM and LB, then Symbiotica. Stand, get ready. We may get to you sooner than you expect. So it's 1:15 now. Please go ahead.
I'll use the mic there.
You have somebody there to change for you. I don't know, it's not working. I think the battery's down. Okay. Please go ahead.
All right, so good afternoon.
My name is Dr. Laumi Adaramoye, consultant obstetrician gynecologist from Lagos University Teaching Hospital. I'm also with the College of Medicine, University of Lagos. So I'm presenting on behalf of the Center of Clinical Research and Implementation Science, which is domiciled in the College of Medicine, University of Lagos. I'll stand on the existing protocol. Before I go ahead, I'd like to call on the members of the panel for this discussion. Associate Professor Kehinde Okwade, please can you join me on this here? Dr. Mr. Hamid Adelabu and Mr. Badmos would also join me. So I'll be running through this presentation quickly so we can that you'd have a do. Basically, we're looking at the conduct of clinical research in low resource setting, and we're going to be sharing our experience as a center for clinical trials and implementation science. I'll start on the backdrop of what someone said yesterday. She said we're not doing clinical research, so much clinical trials within the country or even in Africa, and many of us serve as guinea pigs for the white people. But I'd rather like us to follow me with this presentation and listen to what I have to say. Please, the next slide. So who are we and what do we do? We are we're a pioneer center which is focused on health research and implementation science. And as I said, we are within the College of Medicine of the University of Lagos. And our primary focus is high quality clinical research, also focused on behavioral science research, training, and networking. Please, can we go on? So we have different icons there to show in focus what we do. So we have, we provide support services. We foster international collaboration, networking. We provide clinical research training. We also conduct high quality research and promote implementation science. Now, our projects. I'd like us to go through what we do. So we have a series of 7 trials or 7 research work going on, 5 of which are clinical trials. 2 others are also stated there. Most of them are mnemonics for us to be able to remember what we have to discuss here today. So number 1 there is PIPSICO trial, and here we just have a snap summary of what exactly we are doing with these trials. So a snap summary of what we are doing. I'm going into more details of this presentation. Yeah, thank you. Okay, so the first one, as I said, is a clinical trial, which is PIPSICO trial. The second is IVON trial. The third is SPEC AI. The fourth is IVON PP trial. The fifth is IVON IS. The sixth is IZINV. And the seventh is ELVASA SRS. And all these names are there for us to be able to remember easily what exactly we are doing. So I'm talking about the IVON trial, which is a trial which has already been completed, but I'll just give a summary of what we did with, during the trial when it was conducted. Our primary focus was on IV iron, that's intravenous iron use, which you know that many centers or many places, even within the country, would not want to use intravenous iron. Many of us still use oral iron routinely, either for fears of the side effects or because we think it's going to be too long to administer it. But this trial, IVON trial, the main title is Intravenous versus Oral Iron for Iron Deficiency Anemia in Pregnant Nigerian Women. It was a randomized control trial, which was open label, parallel design, and it was conducted in 2 states within the country, Kano and Lagos, in 11 sites across these sites within the states. And the intervention drug was intravenous ferric carboxymaltose. The interesting thing about this medication was that it was just given as a single dose, and it was administered to women who were recruited within 20 to 32 weeks, and these women were followed up until when they were 6 weeks postpartum. And the primary outcome for this research was for us to look at how many women were anemic, that's with a hemoglobin less than It's not stopped. Please, can you help change the slide? I think she's working on it.
Are you the one stopping it from moving?
Okay, so the primary outcome was women that are 36 weeks with hemoglobin less than 11 grams per DL, that is those that have maternal anemia. And at recruitment, our focus was women that had moderate to severe anemia, as at the time we recruited these women. And also the second primary outcome for this trial was preterm birth, that's delivery less than 37 weeks. Other things that we looked at was the safety and tolerability of these medications. We looked at maternal events or adverse events. We looked at infant outcomes such as birth weight mortality and also maternal depression, of which we used the Edinburgh postnatal depression scale to assess this. Now, I said we're a center that deals with both clinical trials and implementation science research. And so there was a second arm for this trial, or a secondary aim, of which we had an implementation aspect. And the primary outcome for this was to check accessibility, feasibility, fidelity, and cost effectiveness with the use of this medication. And the primary stakeholders, which we have displayed there, we have health workers, we have pregnant women and their partners, health facility managers, state government health officials, and we had policymakers, which we had key informant interviews and we had focus group discussions with these people to help us during this research. Now, overall, what we found with this research was that 43% of women had anemia at 36 weeks gestation, of which 10% of them had moderate to severe anemia, and 40% of this was due to iron deficiency anemia. Now, following administration of the IV iron at the time of enrollment, and for those that had the oral medication administered to them, we noticed that there was a significant reduction in the level of iron deficiency within these women, as we can see as displayed there, and also iron deficiency anemia. We had a significant improvement in those that had IV iron compared with those that had the oral iron administered. Also, we found that 4 weeks post-administration of this medication, we found that there was a significant improvement in the mean hemoglobin level of the women that had IV iron as compared to those that had oral iron. And this study or this research has been completed and it has been published, and that is the link for us to be able to access this research work. I'll be going on to the I1PP trial, which is ongoing presently, which is intravenous ferric carboxymaltose versus oral ferrous sulfate for the treatment of moderate to severe postpartum anemia in Nigerian women. And what we focus on with this is also on administration of intravenous ferric carboxymaltose in these women in postpartum period versus our routine medication, which is oral iron. And we also know that among these women, many of them do not like the oral iron. They complain that it's difficult to take, causes bloatedness, constipation for some of them, and so many things. And because of that, many of them even forget to use it because they have to care for the babies. But a single dose of IV iron was also given to these women within 6 hours of delivery to 48 hours. And following this, we followed up these women to do a 6 months postpartum. And then what were our primary focus? But just to tell us what exactly, this was a multi-center, also parallel, open label superiority, randomized control trial, which was conducted, or which is being conducted because it's still ongoing, in 4 states across the country. So we have in Lagos, Rivers, Kwara, and Kano, across 20 sites within these states. And we have, our focus is 1,400 postpartum women, of which we have recruited these women completely, and which we completed by June 2024. And we focus to have, or we plan to have our last participant last follow-up visit by January 2025. And hopefully results will follow, and also we'll be able to present this hopefully at the next conference. And our primary outcome for this is women that will be non-anemic with a HB greater than 11 grams per DL by 6 weeks postpartum. So we have the PIPSICO trial, which is low-dose aspirin for preventing intrauterine growth restriction and preeclampsia in sickle cell pregnancy. And this is also a multi-center randomized placebo-controlled double blind parallel trial, which is ongoing, which we focus on administering 100 milligrams of low-dose aspirin to women who have either HBSS or HBSC within 12 to 28 weeks of their pregnancy, and they are followed up onto 6 weeks post-delivery with the aim of either achieving a reduced risk of intrauterine growth restriction, preeclampsia, prenatal death, miscarriage, or other complications among these participants that are enrolled. The plan is to have 476 women, pregnant women enrolled, of which we have completed the enrollment, and now they are just having follow-ups, of which we also hope that by the time by the first quarter of 2025, we would have completed the follow-up visits for these participants. Later today, we'll be having some presentation on some SNAP research work which we have produced from this PIPSICO trial. During the oral presentation, we welcome you to please listen because you also have some more in-depth information about this. And this trial is being conducted in 2 states. We have Lagos and Osun State, and we have 16 health facilities within the states. The next is PEC AI, which is also being conducted within the center, and it's also a completed trial. It's screening for postpartum cardiomyopathies using artificial intelligence. We know this is a new focus of research now. Everyone is talking about AI. And most importantly, I'll just run through it. We've completed this already. I'll just talk about what the result was. And also the paper is available. The link is there so we can follow it to go through it. But we found out that AI-guided screening with a digital stethoscope doubled the diagnosis of pregnancy-related cardiomyopathy when compared to the usual obstetric care with high sensitivity and specificity. So please, I will advise or I will encourage us to please, we can also go through this. This research has already been completed. So it's also a clinical trial. IVON-IS is a pure implementation science research that is being conducted. It's all conducted in Lagos State, Nigeria. Its focus is, the title is Implementation Research for IV iron use in Nigeria. And the primary aim of this research is for us to strengthen routine screening for anemia during and immediately after pregnancy, and also looking at conditions within the health system to deliver IV iron to pregnant and postpartum women with moderate to severe anemia. And the primary outcome of this study will be implementation fidelity, that is, being able to use these medications and to achieve the outcome which we desire. Presently, this research work is in its 2nd year, and hopefully by the end of the 3rd year, we'll be able to present the results and the outcome from this research work. Just about to kick off is the AZIMV trial, which is azithromycin use in labor to prevent maternal sepsis among pregnant women undergoing vaginal birth in Nigeria. And we know that maternal sepsis is among the top 3 leading causes of maternal mortality, and even globally, it accounts for about 10% of maternal deaths. And it has been shown that a single dose of oral azithromycin given to women while in labor, 2 grams, is safe and effective and can reduce the cases of maternal sepsis or death during vaginal delivery. And this is a clinical trial also with an implementation study in it. The plan of this research is to have 5,040 pregnant women with signature or multiple gestation enrolled from 24 weeks of gestation, either having a live or a stillbirth, and then these women will be across 60 sites within the country, and we're using 6 states within Nigeria, representing each geopolitical zone, so that we're having women that are representative of at least almost everyone in Nigeria. And this, we have 48 sites to be conducting the randomized control trial, while 12 sites will be having the implementation research conducted. And basically, our plan for this is to find out how many women at 6 weeks postpartum will have maternal sepsis. So that's the outcome for this research. And presently, we're training staff to get this running, and we'll be starting the pilot hopefully by the end of November. So I also advise us to keep an eye out, to watch out for this. Next is the LVASA SRS, and this is Lagos State Verbal and Social Autopsy Sample Registration System, and it aims to collect accurate data on maternal death and stillbirths to inform health policy decisions. And what exactly is our drive for this? We know that Nigeria has a significant challenge with low utilization of civil registration and vital statistics. And because we don't have accurate data, it's difficult for us to implement either things that we want to use to help reduce maternal mortality or any other mortality that is in place. Now, this research work is being conducted in Lagos State, Nigeria, and the aim is to establish a statewide SRS in the first instance to generate reliable statistics or estimates of maternal deaths and stillbirths in Lagos State, and to determine both the common causes of maternal deaths and community factor that contribute to maternal death in Lagos State. And we hope that with this information, we'll be able to improve maternal mortality data that is collected and assist Lagos in targeted interventions to reduce maternal mortality. Presently, this is a mixed method study design, and we're still getting set to kick off. So very soon, this also will be this. So what else do we do? Is it just about research? No, we're also about capacity building and strengthening. We do academic seminars. I know some of us attend these seminars, which we hold at least a minimum of once a month, where we have presentations. We look at things that are happening in real time, how to improve ourselves, and everyone is welcome to join. We have journal clubs, and this is an international event with the University of Nottingham, which we have also every month, and everyone is welcome to join. We run short courses, and also this, when I get to the end, I'll show us the link to the website so we can all have access and everyone is welcome to join. We have postgraduate programs, both in clinical trials and implementation science, which everyone also is invited to come in. It might not just be for us, also we can ask others to join. We do internships also for people that want to train and learn how to do research work, clinical trials, implementation science research. All this we do at the center. Before I say my final thank you, I'd like to recognize the director, Professor Bosede Afolabi, and to thank her for this privilege to be here to present on behalf of the center. I also like to thank all the members and our great team, because they're doing a lot of work, as you can see, and most importantly, our women and their families. They are doing a great work with us. And to Sogon for this opportunity, we say thank you. The next phase of this will be the panel discussion. Any questions which we'll have, we'll answer them all together. And I say thank you very much.
Thank you very much, Dr. Adaramoye, for cutting your time, really cutting your time. I guess you want to handle the panel discussion. Does anybody have questions for the CC3 session?
Do you have any questions or anything you want us to clarify? Yes, sir. Please, Prof. Ezechi has a question. Please, can we get the mic to him?
Thank you. Let me appreciate the CITRIS team for what people are doing, and especially our wife. The husband is my colleague in Naima. Well done. My question is, I have a center in Naima I'm managing, but my challenge is managing human resources, personnel. How are you people coping to be able to have been successful? Managing people is actually my work. It's not getting the money to do the work, but managing people is the challenge. Thank you. I want to learn from you people.
Thank you, sir. I don't know why Dr. Adaramoye handed the mic over to me. Okay, just to declare, I'm a deputy director at the center. So, actually, even though the center is domiciled at the College of Medicine, University of Lagos, the administrative system is actually separate from the university system, because we know the bureaucracy and the challenges that come with that setting. So it's actually managed more or less, even though we are under the University of Lagos, but it's managed more like a private entity. Some of the staff actually double as staff of University of Lagos, but of course they be seconded to the center, while most of them are actually employed solely by the center. So it has nothing to do with. So, and of course, other than the fact that we have a director, we also have about 3 deputy directors, among which I belong. So, and of course, we handle different administrative parts of the center. And I think that's what makes it work very well for us. Thank you.
No more questions. So thank you, CC3, for your presentation. Thank you very much. That's all. Clap for them. DCL Labs, are you ready now? DCL Labs. UD Medical. Okay, DCL is ready. So we have CFAM, LB, LBI, and I think Symbiotica or Sanofi. Those are the only presentations we have left. Okay, sir, you have 2 presentations. You have one now. So please take this in 15 minutes, sir.
Okay, thank you so much. My name is Olushola. I represent the company CareGen, GmbH. CareGen is a German company. We're a spin-off of University of Düsseldorf.
Speaking to the mic, please.
Okay, is it better now?
Yes.
So today I'll be speaking on enhancing ROM management, the role of amnesia in accurate diagnosis and patient care. ROM, which is the rupture of the fetal membrane before the start of labor, usually occurs before 37 weeks of gestation. And this occurs between 3 to 8% of all pregnant women, and it leads to drip in the amniotic fluid and an increase in the amount of infections that can happen. There are different risk factors for PROM. One is previous infections, the body mass index, the maternity, the maternal age, the parity, the social, educational, and occupational status of the patient, the lifestyle, smoking, trauma, stress. This all leads to higher risk factors for PROM. There are traditional ways of diagnosing this. Either you use sterile speculum to confirm the leakage in the amniotic fluid, or the use of traditional tests such as nitrazine or Fen test to identify leakages in the amniotic fluid. Or you can also use ultrasound to assess the level of the amniotic fluid and the well-being of the foetal. This next slide, please. We have so you can see the 4 different ways that is being used at the moment: nitrazine, ultrasound, phenin, or the gold standard, which is the aminodye infusion. So, but each of these comes with different strengths and weaknesses. For example, when we use nitrazine, studies have shown consistently that 50% of the women that are regarded as positive are false positive. And in the case of phenin, it is the opposite. Almost 50% come with false negative results. And we can reduce the level of false positive and false negative by combining this test using nitrazine, phenin, and also combining with ultrasound. But with amnesia, we have been able to see that using a different biomarker, we can reduce the amount of false negative and false positive in rupture of the membrane diagnosis. So what are the markers? We are using PAMG1 compared to nitrazine and phenin. And in the next slide, you can see, go back. You can see the difference in the overall specificity and sensitivity of this test. And you can see that when you use the biomarker, the PAMG1, you have a sensitivity and specificity that is close to 100%, unlike the traditional method of nitrazine, phenin, that is just about 68, 71%. So this makes the case for it. And why is this so? What is amnesia? It is a rapid qualitative immunochromatography test for IVD detection of placenta alpha microglobulin 1 in vaginal secretions of pregnant women. The test is designed to be used by healthcare professionals to aid in the detection of the rupture of the fetal membranes in pregnant women. So what is PAMG1? This is a small protein. It is formed by decidual cells, and it is released into the amniotic cavity throughout the pregnancy period. So what does this mean? It means you can carry out this test irrespective of the stage of the gestation. This protein, PAMG1, is found in high concentration in the amniotic fluid. Of course, there are low concentrations that can be found in vaginal discharge, but this is so low, and what you found in the amniotic fluid is between 2,000 and 25,000 nanogram per mil, unlike in the vagina where you see it at 0.05 to 0.2 nanogram per mil. And what does this mean is that we put the markup, the threshold for the detection to be above what naturally occurs in the vagina, so that once it is positive, we know that we can rule out accidental occurrence in the vagina. We know that this is definitely a rupture of the membrane. And there have been a lot of data published on this. But even in Nigeria, we've seen quite a lot of published data. Next slide, please. We in almost all the countries. In Nigeria, we've seen Professor Eleje et al. Running some studies here, 2015, and I think I saw him yesterday. We have Professor Adebara. So there have been quite a lot of intensive studies done in almost every country on the world on the applicability of amnisure and on the sensitivity and the specificity of the test in determining the premature rupture of the membrane. So what are the benefits? Again, this is the only test that is close to 100% in sensitivity, in specificity. There is no limitation to the gestational age. You can get your result and you do not need any speculum examination. And simply because it is detecting the PAMG1 biomarker in the amniotic fluid. This is the only test that correlates 99% to the current gold standard, which is indigo carmine aminodye infusion. How do you run the test? It's a very simple test. It's a test that can be run right there by the side of the patient, and you get the result in less than 7 minutes. So all you need to do is dip the swab 2-3 inches deep, withdraw it and put it in the reagent box, and then you watch it. It's as simple as just the same way you do a pregnancy test, and then you watch your results after 5 minutes. Once you have double stripe, next slide please. Once you have double stripe, then you know that the patient is positive, and this is definitely a premature rupture of the membrane. If only one control line is visible, then the result is negative, and if you don't see any line at all, that is an invalid test. So you can see the diagram on your projection, and that is how simple it is. The whole test, from collection to seeing the result, is less than 7 minutes. So again, move on. Next slide. So again here, how does it work? The patient comes in with signs and symptoms of ruptured membrane or leakage of the amniotic fluid. You run the test. If the test is negative, you can rule out rupture of the membrane. And if the test is positive, then you have to go back to the recommended guideline, giving in antibiotic therapy, antenatal corticosteroids, magnesium sulfate, and the rest. So amnisure, in summary, is a reliable tool for prompt diagnosis and management. It has a high diagnostic accuracy. It has shown and it has been demonstrated higher excellent sensitivity, close to 100%. So there are no false positives there. Extremely low false negatives. So highest excellent sensitivity, excellent specificity, and reliability for the diagnosis of premature rupture of the membrane. It has consistently, in all the studies done, all over the world, including in Nigeria, outperform the traditional methods like pooling, phenine, and nitrazine tests. It is easy to use. You don't need any equipment, and you don't need to support it with speculum examination or the rest. It's a simple bedside test that can provide quick and accurate results without requiring any specialized equipment or laboratory analysis. Even a nurse can run this very simply. It's applicable globally. This is a CEIBD test. It's a FDA test, and almost every country of the world have adopted it into their HMO payment system. And it is also comfortable for the patient to use. So that is it on AmniSure. If you want to get samples of the test, or you want us to train you deeply on how to use AmniSure, please come to the DCS stand. We can give you some samples and we can teach you how to run the test. And we can also do that.
Thank you very much. Really appreciate you. I think you have another presentation for us later on in the day. Okay, so let's go now to, I don't know, Uni Medical, not here. Good. ZFAM. ZFAM, you are on me for a while. You have 7 minutes, ZFAM. If you look at your book, we can see we're at 3:10 now. So we're now ahead. We're an hour, 20 minutes ahead. Clap for me now. You know, easy. So I'm just joking, you don't have to clap for me, but I think we have done quite well. So we can get over with. Lunch is almost ready. I can hear them. I saw some movements upstairs. So once lunch is ready, it's not going to be like yesterday. Once lunch is ready, we'll have lunch. Please don't go away. Lunch today is very powerful. I've been told that if you take the lunch, you may not wake up till tomorrow afternoon. Very sedative. Are we ready, ZFAM? If ZFAM is not ready, LB should get ready, then Cibautica, then we are done. So, ZFAM, you have 7 minutes. Time starts now.
You are trying to do cut down.
Yeah. Good afternoon, everyone. My name is Abayomi from ZFAM Pinnacle. And ZFAM is an Australian multinational company, and we've been participating in Sorghum for some time now. Because of time, I would rush through.
This one is to go forward. This one is forward. This one is forward. This one is backward.
Okay. It's not working.
This one is forward. Point it towards that machine, not the slide. Point it that way, that direction. Okay, point it there, that way. Not here. So let me take it back. Okay, leave it. So this is forward.
Okay, we are into nutraceuticals and pharmaceutical range of products, all made in Australia. And of course, with latest pharmaceutical technologies, highly certified by TGA Australia, well represented in over 40 countries across the globe. With presence in Nigeria, you can see the array of products that we have in the country, ranging across all specialty, especially in gynecology with our ZQ and NatoCare Plus. But quick one, 1 in every 4 infection in women, usually urinary tract infection, which is actually quite a menace. And 7 out of 10 women complain of UTI before or during, menstrual periods. But of course, we already know what UTI is. There's no need to go through that. And the unique characteristics of the urinary system, the close proximity between the vagina and the urethra. So that's the unique characteristics, which we're talking about the organism involved in urinary tract infection, most especially E. coli, contribute to about 90% of these cases. And the chronic problem is the fact that of recurrence. 1 in 5 women we have, about 20% of this we still have another, and on like that, about 30% also we still have another recurrent. So it becomes a burden. And of course, the common risk factors are the menstruation, sexual activities, indwelling urinary catheter, renal calculus, and of course, history of UTI before the age of 15. And constituted through the female's life, through reproductive life, during pregnancy or surgical procedures, and of course in post-menopause as well. And of course, management of UTI, actually we are looking at something beyond antibiotics. Why? Because of recurrence. You know, in the course of recurrence, the patient might not necessarily have to consult the doctor. The patient will have to go over the counter to pick an antibiotic, and in the course of that, abuse of antibiotic come into play. And with the abuse of antibiotics, antibiotic resistance also coming. And this might lead to other side effects, you know, antibiotic-associated diarrhea amongst, you know, other cases. And of course, in case of it, factors associated with menopausal women also. So with that, I'm introducing to you our Urisol. Urisol is a unique brand. It's containing cranberry extract, which has the active component proanthocyanidin plus added alkalizer. And how does Urisol work? The cranberry extract basically attaches itself to the E. coli and preventing the attachment of the bacteria on the urethral wall of the urinary tract. So basically that is how it works. So it's been eliminated via urination. So indications basically is in adjuvant for urinary tract infection with antibiotics. It can be used in recurrent urinary tract infection and also as prophylaxis, very important. And of course in prophylaxis for catheter-induced urinary tract infection and for elective gynecology surgery as well. And the use is usually taking 2 to 4 sachets maximum per day. It can be taken once daily or twice daily, depending on the severity. Usually taken for 5 to 15 days. The baseline is minimum 5 days. And the administration for use is actually dissolved in a small glass of water and taken. You just the way Andrew liver salt is taking effervescent drink. You just have to drink twice daily. Someone will demonstrate that while I continue with my presentation, how to use our Urisol. It's just basically an adjuvant and prophylaxis in urinary tract infection. So quick one, going to the last one, the vaginal flora. Normal flora contains mainly lactobacillus, ranging pH of course, normal pH of the vagina is 3.8 to 4.2. But then there are other factors that affect the vaginal flora, like the close proximity of the anus to the vagina, shorter size, menstruation, sexual activities. All these factors affect the vaginal flora. And disruption of the vaginal flora might lead to, as a result of the low levels of lactobacilli, leading to low level of adrenal peroxide production and increase in vaginal pH. This might lead to overgrowth of bacteria or other abnormal discharge. So we will not bore ourselves with that. So the probiotics basically restore the vaginal flora by increasing the adrenal peroxide production, bringing down the vaginal pH, and of course restoring the vaginal flora. And of course, oral probiotics for vaginal health basically goes through the anus down into the vagina and protects the vaginal flora. So with that, we are introducing to you our Oxyflora V. Oxyflora V is a oral probiotics specific for the vaginal flora. It has a specific strain, well studied, Lactobacillus rhamnosus, Lactobacillus acidophilus, specific strain for the vaginal flora. And of course, it's indicated in maintaining healthy vaginal flora to prevent recurrent candidiasis, bacterial vaginosis, amongst other abnormal discharge. Dosage usually 1 capsule to 2 capsules daily and can be consumed before meal. Duration is minimum 10 to 15 days as well. So it helps to restore the normal vaginal flora within 15 days and improve symptoms of abnormal discharge, reduce itching, and reduces fishy odor. And of course, just to draw the curtain, we have our EpoSoft Evening Primrose 1000 milligram. which of course for premenstrual syndrome and of course for skin. The ladies will like this very much. And of course we have our Ozical. Ozical is a unique formulation. Milk calcium. The calcium hydroxyapatite, that's the one present in our bones, unlike the ones we have in the market that are carbonate and the likes. But this is the organic form, which is well absorbed by the body. Also has vitamin D3. The unique thing is that it is chewable, orange flavor. So I would like to draw the curtain there and say thank you very much. Our stand is just behind there, opposite Swiffer. You can come around. We have a taste challenge going on. You can come around and taste our Urisol, and of course purchase another questions or queries. You can come in. So for those who want to taste as well, they can reach out. Thank you very much, and God bless.
Thank you very much, sir, for keeping to time and presenting well. That's Zifam, right? LB, are you ready? Or is it LBI? Are you ready? You have 7 minutes, please. I think that's the last presentation. Is there anybody that have not called? Which one is that? LB. No, that's LB now. After this, nobody else? You are what? LB. Is that, are you LB? Eh?
The one standing is LB. It's LB.
Okay, I didn't hear what you were saying. Go ahead.
Okay.
You have 7 minutes.
Yeah. Thank you very much. Good afternoon, everybody. My name is Dr. Nsika Kinyoyoko. I will be representing Derivite Pregbone Plus, and I'm presenting prenatal nutrition for the best outcome in pregnancy. Can we get this slide up? Well, as obstetricians, we all know that the most desirable outcome in pregnancy is a live birth, and we know that the challenges faced in pregnancy includes severe nausea and vomiting, gestational hypertension, gestational diabetes, iron deficiency, anemia, preeclampsia and eclampsia, preterm labor, low birth weight and stillbirth. Next slide, next slide. Yeah, okay, next slide. We know the importance of prenatal care, which in our clients we call antenatal care, is to ensure the healthy growth of the fetus, sound health of the mother, and ensure that we have a safe and live birth, reduce all the risks and complications of pregnancy, and manage the health challenges in pregnancy. Here I'm introducing Derivite Pregbone and Pregbone Plus by Elbe Pharmaceuticals, and these products provide essential vitamins, minerals, amino acids, fatty acids, and antioxidant support. These are the contents contained in the formula. We have the vitamin group A, B, C, D, E, K, folic acid, B12 and B6. Then we have minerals. The minerals include calcium, magnesium, copper, zinc, selenium, iron, iodine. Then we got amino acids, lysine, arginine, and we also have inositol and the mixed natural carbonoids. I'll just take a few of them one by one, a word on each of them. Essential, lysine is essential, it's an essential amino acid that is important in collagen formation and helps in the absorption of calcium, zinc, and iron. Arginine, next slide, regulates uterine and fetal placental blood flow, helps uterine smooth muscle relaxation, and inositol, the next one. Inositol has come up here earlier on, and I'm sure we all know a lot about it, but it's very important for tissue osmoregulation and reducing fasting blood glucose levels in GDM, gestational diabetes mellitus. Yeah, Pregbone Plus. Pregbone Plus has the addition of omega-3 fatty acids to what we already have in Pregbone, and the omega-3 fatty acid is important for the fetal brain and retinal development. The carotenoids are the source of vitamin A in this product. We know the benefits of vitamin A, I will not bore you with that. Vitamin D3 is important for modulation of the immune system and also prevents neonatal rickets and osteomalacia in the mother. Vitamin E is an antioxidant that helps against oxidative stress. Vitamin K, popular vitamin K, for blood clotting and coagulation. Vitamin C, another antioxidant, boosts immunity against viral and bacterial infections, reduces the number of circulating antihistamines, and helps in the absorption of iron in the body. The B complex, all the Bs, they work synergetically to achieve an optimum benefits for the woman. They are all listed there. I think I should just go skip them. We have folic acid. We know folic acid is very important in fetal DNA synthesis and also protects against anencephaly and spinal bifida, like spinal cord defect. Vitamin B12, that one takes care of nerves. We know it helps with neurologic functions, and then iron is very important for blood cell formation. Copper also helps in blood cell formation, improves the function of the fetal heart, blood vessels, skeletal and nervous system. Magnesium assists calcium in doing its work. Zinc is important for normal immune function and reduces severity of infection. Iodine is good for thyroid function. Next, selenium has antioxidant role in cell function, helps in a lot of protection against free radicals as well. Yes, now we introduce Pregmon and Pregmon Plus. It's a soft gel. It offers the advantage of easy swallowability. Let me use that word. It's easy to swallow, it's easy to accept, no smell, no nausea, reduces nausea and that. It's recommended where you need daily nutritional support in pregnancy. Also recommended where micronutrients malnutrition exists in pregnancy. If there are health challenges in pregnancy, it can be given as an adjunct to treatment. It also improves the pregnancy outcome as our desirable product. Now, I've mentioned all this before, but added to it is the aesthetic appeal of being a soft gel. The cost effectiveness is actually cheap and it's available from a reliable source. Elbe is a reliable source. I have 1 more minute to tell you a good thank you. Thank you for listening. Elbe Pharmaceuticals have come here to celebrate all the pregnant women, and they have a cake. They donated a cake to Sogon to celebrate pregnant women. Thank you very much for listening to my presentation. God bless you all.
Thank you very much. Is that a cake that should be cut?
Yes.
Where is the president? Is he around? He just stepped out. First Vice President. Symbiotica, load your slides, please. Taking you next. Load your slides. Once we take this after lunch, we go to the parallel sessions. Then we're done. So presenters who have your papers, abstracts for presentation, get ready. Professor Akiola, please join us. E, L, B, E. Exactly. Some of them are traditional wedding they do.
Thank you.
Thank you very much. Symbiotica, are you ready? Please join us on stage, please. Let's take your presentation. Then after that is lunch. Then the parallel sessions. Then is dinner. Symbiotica. I don't know the title of your presentation. It's loading. Okay. Are they ready? Are you ready with the slides, please? You have 45 minutes. Okay, you're on stage with them, Abi? Yes. Okay, let me hand over.
No, wait.
What's that? Okay. Now they chop this and money. Now they chop and money.
All right. Good afternoon, everyone. My name is Pharmacist Franklin Ewelike, representing Symbiotica, and today it's a privilege to have on the high table Professor Badegesan and Dr. Lehman, and they will be leading a panel discussion on a topic I consider very crucial to our practice, and I believe that by the end of these 45 minutes, we will all gain value for our time. So just permit me, I think the slides are ready now, it's on the screen there, so permit me to just quickly hand over to the persons that will be leading the panel discussion. Please help me with a round of applause as I make welcome Professor Badegesan.
Good afternoon, ladies and gentlemen. Yeah, we are going to discuss VTE in women. VTE is venous thromboembolic events in women. So we're going to talk on gynecology, and we're going to talk on women and pregnancy. Venous thromboembolic event is a major cause of preventable morbidity and mortality. And hospital-acquired thrombosis accounts for about 50 to 60% of all thromboembolic events. Not only this, it has considerable cost implications, both as prophylaxis and as treatment. Now, there are a lot of guidance when it involves thromboprophylaxis in patients who are pregnant or those that are going to have surgery. But in gynecology, there's paucity of guidelines. And we do know that gynecological surgery presents unique risk factors for thrombosis. Venous thromboembolic event occurs in the form of deep venous thrombosis or pulmonary embolism. Deep vein thrombosis, the formation of a thrombus in the deep veins. It occurs most often in the veins of the leg or thigh and is associated with swelling and pain in the affected limb as major symptoms. Pulmonary embolism occurs when part of this thrombus breaks away and gets lodged in the venous bloodstream, especially in the pulmonary artery. The typical symptoms and signs of pulmonary embolism include shortness of breath, respiratory-dependent chest pain, hemoptysis, syncope, and sometimes death. Venous thromboembolic event is a leading cause of disability and death in postoperative hospitalized gynecologic patients. Pulmonary embolism has a case fatality rate of approximately 12%, with lower rates in younger patients and higher rates in patients with cancer. When a patient is first diagnosed with venous thromboembolism, the incidence is about 1 to 2 per 1,000 individuals per year. Patients at bed rest are 9 times more likely to develop venous thromboembolic events than the general population. So in most of our gynecological surgeries that are going to, and even pregnant patients that are going to have bed rest, the chances of developing thrombosis is very high, and there may be need for thromboprophylaxis. The odds ratio of increased VTE risk in hospitalized and surgical patients is about 11.1 and 5.9 respectively. The risk is 60-fold higher in women during puerperium than in non-pregnant women. And the risk peaks at about 3 to 6 weeks postpartum, declines rapidly thereafter, but the risk still persists for up to 12 weeks postpartum. VTE is a frequent disease affecting more than 1 million people in Europe and also very common in the developing world here. The incidence is about 1 in 10,000 in young people, especially less than 25 years of age, and that rises to about 1 in 100 persons per year in the elderly, people that are above 75 years. Looking at the epidemiology and challenges for VTE prevention, over the last decades, the incidence has not changed, and obesity and cancer happens to be major risk factors. After the thrombosis, there could be post-thrombotic syndrome, which may also be a kind of morbidity for the patient. Without thromboprophylaxis, patients who undergo major gynecological surgery have a prevalence of DVT in the range of 15 to 40%. It could be symptomatic, it may not even be symptomatic. And asymptomatic DVT is also highly associated with the development of pulmonary embolism. When people develop pulmonary embolism, the fatality is usually very fast, usually within 30 minutes, leaving a very narrow window for medical intervention procedure itself. Factors pertaining to the procedure include the location of the surgery, the technique that is used, the duration and the type of anesthesia administered, the potential for infection, and the extent of the postoperative immobility. In gynecology also, there is association of venous thromboembolism with combined oral contraceptive use. And the risk reduces with increasing duration of use, but it remains above the background risk until the combined hormonal contraceptive is stopped. It is not advised in women greater than 35 years, especially those who smoke, and those with BMI greater than 35 kilograms per meter square, or those above 45 years of age with family history of venous thromboembolism in the first degree relative. If anybody is on combined hormonal contraception and that person needs to undergo surgery, effort should be made to stop the contraception 4 weeks before any major surgery. Progesterone-only methods of contraception do not appear to be associated with this increased incidence of VTE. There's also association of VTE with hormone replacement therapy. In Women's Health Initiative study that was done in USA, there was an increased risk of pulmonary embolism in women who are using hormone replacement therapy. The mechanism is very unclear, but we can just summarize that hormone replacement therapy should be avoided in a patient with high risk of venous thromboembolic event. The pathogenesis of VTE, thrombi formation or the thrombi composed predominantly of fibrin and red cells. And for thrombus to occur, Professor Rudolf Virchow in 1858 proposes association of stasis, vascular injury, and hypercoagulability to be very essential in the formation of thrombus. And that has been represented in a triangular form like this. The association of venous stasis, vessel injury, hypercoagulation promote venous thromboembolic events, which are mainly DVT and pulmonary embolism. There are so many risk factors ranging from cancer to heart failure to stroke, to injury or surgery, long-term use of hormone contraceptives, age over 60 years, pregnancy, injuries or fractures, prolonged sitting, prolonged hospitalization, obesity, and varicose veins. These risk factors can be described, but for the reason of time, I will only mention the prolonged immobility, age greater than 40 years, stroke, paralysis, obesity, major surgery, duration of the hospital stay, varicose veins, indwelling central venous catheter, nephrotic syndrome, pregnancy or estrogen use, and thrombophilic disorders. Gynecologic surgical patients are classified preoperatively into about 1 to 4 risk categories. There is the low, there is the medium, and there is the high and the highest risk. This classification is used to determine the most appropriate thromboprophylaxis regimen for specific patients. In other words, each patient is individualized in terms of their thrombosis risk and the thromboprophylaxis that they will be needing. Based on the procedure type, duration, age, and presence of additional risk factors, a risk of venous thromboembolic event can actually be determined. Now, this is done by scores, and the first person to actually propose the use of scores in assessing the risk of venous thromboembolic event is Caprini. And he categorized them into, very low, moderate, or high, based on scores and based on the risk factors. For patients that are between 41 years and 60 years of age, scored 1. So also, if the surgery is going to be minor, if the body mass index is less than 25, if there's swollen legs, varicose veins, and all the rest. Now, and 2, if the age is between 61 and 74 years, if there's malignancy and the surgery is major, that will be lasting more than 45 minutes. If there's going to be immobilization also for more than 3 days, it's scored 2. For people that are more than 75 years, the score is 3. If the patient has had history of VTE before, the score is 3. So also are patients with prothrombin mutation, lupus anticoagulant, and anticardiolipin antibodies. Patient who has had stroke in the previous 1 month is scored 5. Okay. And the risk level determines the recommended prophylaxis that can be done. It's not only Caprini that gives this scoring technique. There's also the one they call Rogers score that is used mostly in US, which also gives the risk point 1, 2, 3, 4, 5, okay, and can also classify as low risk or high risk. We also have Padua prediction score, okay. This also produces scores related to the risk factor, and high risk of VTE is said to occur when somebody scored more than 4 points. Now, using Caprini, which is very common here, we can say that patients that are categorized as very low, that's Caprini score of 0, the risk of developing VTE is less than 0.5. Whereas, when it is very high, greater or equal to 5, the risk is really very high, almost 6%. Now, depending on the risk level, DVT risk without prophylaxis in low risk will be less than 10%. So for such people, no specific thromboprophylaxis is suggested, and early and aggressive ambulation is suggested. But for people with moderate risk, if no prophylaxis, the risk of DVT is about 10 to 40%, and such patients will need low molecular weight heparin or fractionated heparin, or further Parinox. For patients with very high risk, okay, the risk is about 40 to 80%, and also they will need thromboprophylaxis with low molecular weight heparin and also some mechanical forms of thromboprophylaxis. I want to stop here and allow Dr. Lehman to go to issue of pregnancy and venous thromboembolic events.
Thank you, Prof, for making my work easier. Olanka, it's not working. Okay. Okay. I'm going to add to what Prof have said in terms of gynecological services, surgeries that will require, that are associated with venous thromboembolism. I will deal with pregnancy more squarely in this perspective. The context is that maternal mortality has been the bane of obstetric and gynecological practice over the years, and even RCOG is saying women gynecological aspect is somehow not being paid attention to well. So it is only proper that, as Prof have dealt with gynecological talk in relation to venous thromboembolism, we will add the OBS part. Next slide. Well, I think the outline is there, and not much of introduction am I going to give, other than this. All I have here is built. Next slide. All I have here is already spoken about by the Prof, how it's formed, pathophysiology, and so on. Virtuous triad, I will only underscore the fact that pregnancy is a hypercoagulable state. All factors that Prof have mentioned in terms of causation of venous thromboembolism, they are aggravated in pregnancies. Hormones are elaborated, injuries are common, stasis is common, pregnancy truths on the return, venous return, varicosities, and all stuff. Well, the incidence of VTE in pregnancy is variable. The actual incidence is unknown because it's gaining attention in this part of the world. And then what to do to actually make a diagnosis is also something that needs much to be desired. Well, postpartum services, post-mortem uptake in this part of the world, especially up north, is not as high as in other places and other climes, where even if somebody has passed on during postmortem, it could be found that it is actually thromboembolic phenomenon that has resulted in the death. Well, there is heightened risk for venous thromboembolism post-delivery. And studies have shown that emergency CS is twice higher than elective. But any form of CS is 4 times more than vaginal delivery. That presupposes that even vaginal delivery still have the risk of VTE. Approximately 3 in 1,000 VTEs have been reported, to have occurred following cesarean section. And that's the reference. Then thromboprophylaxis. There is a study by Benedict Nwogo and his group that found that yes, there is high awareness of thromboprophylaxis in their studies, but the practice is not there. So it's one thing to be conscious of something, but what do you actually do, or what are you doing about it? Well, the risk, I don't need to go over this anymore. Then scoring and categorizing, the Prof has spoken about it. Now, if there is risk of VTE, what then do you do? Well, Prof spoke about early ambulation in some risk, some other things are supposed to be done. Well, graduated compression stockings are still, in place, and they have a good a good position in the care of some risk of VTE in our patients. Now, from pregnancy to delivery, the risk is high. So the activity of a pregnant woman is also very important. If a woman has to sit for a long period, then some form of exercise, which actually is the main stay now for everybody, especially if you are age 40 years and above, to really actually lift your heels off the ground or put your heels down and then lift the toes off as often as possible while seated. And if possible, you may stand up and then make a short, walk around. All these are geared up to preventing VTE. That cannot be overemphasized in a pregnant woman. Then the kind of clothing you put on too is key. Well, oftentimes we see pregnant women, heavily pregnant, coming with a rubber jeans or a sort of trouser, and then you wonder how she is coping with those kind of stuff. I often ask, have you gone through every woman? Because there you'll be guided on the kind of dresses that you should, do at different stages of your pregnancy. Okay. Well, Prof spoke about what different categories and the risk of, developing VTE. This slide is just a repetition of that, but to say that, yes, Caprini score is what we base most of what we do in actually obstetric part component on, and we shall see that later as we continue with this presentation. So Prof will continue with further presentation on VTE prophylaxis in gynecological surgery. So.
Yes, we have established the need to consider thromboprophylaxis in gynecologic patients and in pregnant women and in patients that have just delivered. But what are the forms of thromboprophylaxis that are available? There are various means of preventing DVT. They can be mechanical, they can be medical. I will just go through the list: graded compression stockings, intermittent pneumatic compressions, low dose of fractionated heparin, low molecular weight heparin, fondaprinox, inferior vena cava filter. Sorry, I don't know whether there's somebody there.
Yinka. Ola Yinka.
This slide is not changing.
Mrs. Olainka.
All right, thank you very much. Now, in high-risk patients, a combined regimen of medical and mechanical prophylaxis may improve clinical efficacy, although there's limited evidence in gynecological patients. Optimal prophylaxis for gynecologic surgery considers the risk of VTE and bleeding complications, as well as the wishes of the individual patients. So there must be specific strategies for specific patients. Graduated compression stockings. This is the third stockings that we use commonly. It's very simple and relatively low cost. Now, it prevents the pooling of blood in the calf veins, and a Cochrane review showed that 65% reduction in DVT formation has been reported in patients when graduated compression stockings are used compared with when there is no prophylaxis at all. But it comes with some drawbacks. Well, if appropriate size is not chosen, it could be a tourniquet and therefore increase venous stasis, which will further increase the possibility of thrombus formation. Also, there could be risk of skin complications like ulcers, blisters, and necrosis. Intermittent pneumatic compression devices is also a method of thromboprophylaxis. And this time around, some pneumatic material is wrapped around the calf muscles and is intermittently inflated and released. It reduces the risk of both symptomatic and asymptomatic DVT, and it's been said to be very effective, reducing the risk of asymptomatic and distal DVT by about 60% and proximal DVT by about 50%. After major gynecological surgery, intermittent pneumatic devices, compression devices, reduce DVT formation as effectively as low molecular weight heparin and low dose heparin. But the problem is that adherence is very difficult. Because of that, the use, one may not be able to get the greatest benefit from its use. When it is used appropriately, there's a threefold reduction in VTE. Low-dose unfractionated heparin is another form of thromboprophylaxis. And when it is used, it's been shown to have a proven efficacy in VTE prevention. The cost is also low. Effective DVT prevention is best achieved when low-dose unfractionated heparin is administered about 2 hours before surgery and continued every 8 to 12 hours postoperatively. Benign gynecologic surgery patients benefit from low-dose unfractionated heparin administered preoperatively and again at 12 hours intervals postoperatively. And gynecologic oncology surgical patients require a different approach of 5,000 units of heparin 2 hours preoperatively, repeated every 8 hours postoperatively in order to effectively prevent VTE. Low molecular weight heparin has been shown to be of proven efficacy in thromboprophylaxis since 1985. It has similar efficacy with low-dose unfractionated heparin in VTE prevention. There are similar risk reduction to intermittent IPC use. Low molecular weight heparin yielded a decreased incidence of perioperative bleeding and wound hematoma when compared to low-dose unfractionated heparin. And low molecular weight heparin is rarely associated with heparin-induced thrombocytopenia, which is also a problem with low-dose and unfractionated heparin. When compared with low-dose unfractionated heparin, low molecular weight heparin has once daily dosing, it has greater bioavailability, it has longer half-life, and more predictable form of pharmacokinetics. The therapy duration varies and is said to be related to history of prior VTE, cancer diagnosis, the age of the patient, and the extended surgical time. But it's been found that 40% of patients with cancer who develop VTE do so more than 3 weeks postoperatively. And when thromboprophylaxis for 4 weeks was compared with that of 1 week duration, it's been found that the risk reduction was about 60% when it was used for about 4 weeks without accompanying increase in bleeding or thrombocytopenia. So the dosing is such that for prophylactic use, there are also oral anticoagulants, and these are factor 10A inhibitors, rivaroxaban, or direct Trop-B inhibitors like dabigatran. The problem is that of cost and availability. There are so many guidelines, as to the use of thromboprophylaxis in gynecological cancer surgery, American College of Chest Physicians, American Society of Gynae Oncology, and American College of O&G, and so many others like that. Royal College of O&G also has their own guideline. It is important that each institution, chooses a guideline and abide with it for continuity's sake. Now, let's assume we have a case of a patient, 68-year-old, non-hypertensive, diabetic, who is being currently worked up for total abdominal hysterectomy plus bilateral salpingo-oophorectomy on account of endometrial carcinoma. Full blood count, electrolytes, urea, creatinine are within normal, fasting blood sugar 89 milligram per deciliter, and anesthetics are already reviewed. It is important that we calculate the risk score for such patients to be able to give thromboprophylaxis. A patient that is 68 years old, the score on Caprini will be 2. The patient who is going to have an extensive pelvic surgery will also have a score of 2. That's 4 already. A patient with BMI of 35 kilogram per meter square will have a score of 1. That's already 5. A score of 5, which qualifies the patient as very high risk. And as a result, the patient needs thromboprophylaxis. There are steps towards effective thromboprophylaxis. The steps will include, deciding whether there's a need for thromboprophylaxis, choosing the anticoagulant to use, and providing appropriate thromboprophylaxis, and also follow-up and monitoring. There are indications to its use. Some are absolute, some are relative. Bleeding disorders is absolute. Hemorrhage is relative. Platelet count less than 50,000 per millimeters cubed is also absolute. I will call Dr. Liman to come and talk about pregnancy case scenarios. No, it's going to just give us 5 minutes.
Yes. Thank you, Prof. I'm here to give a case scenario 2, and this is a 47-year-old non-hypertensive woman. She was booked, Gravida 3 para 1+. She had twin gestation via assisted reproductive technology. She presented at 34 weeks. Her BMI was 33. Blood pressure was 155/110 millimeter of mercury. There was no proteinuria. She had emergency cesarean section and was delivered of 2 neonates with those birth weights, and the estimated blood loss was 500 mils. Now, looking at this patient, we applied this. We applied our adapted Caprini score in the hospital, and we came out with this score, looking at the risks that are clearly off there, and we scored. We got a total of 4, and based on the Caprini score, we interpret it as intermediate risk, and then place the patient on TET stockings and ambulation early. Then we gave subcutaneous enoxaparin. Well, the patient did well. The blood pressure was 160/100 on the second day of post-op, but continue on downward trends, and the patient did well. The Clexane was stopped at the 7th day, and then the patient was discharged on the 9th day. The second case, Olainka. The second case is also a 41-year-old unbooked patient with 3 live babies in her 6th pregnancy. She had had 2 previous cesarean sections. She came in with severe preeclampsia. Okay. No. Yeah, she came in with severe preeclampsia. Her BMI was 38. Her blood pressure was 227/135 millimeter of mercury. There was severe proteinuria, that is 4 pluses, and then associated dizziness. Well, she wasn't in labor, so cervical ripening was attempted up to 3 times while blood pressure is being controlled. It didn't work. She was delivered via urgent cesarean section on 4th day in admission. She was delivered of a live female neonate weighing 600 grams, ABGA scores of 5 and 7 on the first and 5th minute respectively. We used this same tool to score her risk, and then we came out with the score of 5, which is high risk, and then this care was given. Note that the enoxaparin that was given in this case was a higher dose because of peculiarities of this particular patient. And then the patient was managed in our HDU. Okay. Yes, she was managed in the high-density, high-dependency unit of the hospital for the first 24 hours. Pack cell volume was there, and the blood pressure was 150/90. We continued this clexane for the next 3 days. At that time, the patient has become very ambulant. The baby has passed, and the blood pressure was controlled to 130/80 millimeters of mercury on methyl-dopa and nifedipine, and was discharged on the 8th day post-op. Well, in conclusion, next slide. Okay. In conclusion, in the contemporary obstetric practice, concerted effort is essential in, yes. In conclusion, contemporary obstetric practice demands concerted efforts as an essential way of identifying potential patients at risk for VTE, and then prevent this VTE in those patients and as well obviate its sequelae. If this is done, then preventable deaths will be avoided. A stitch in time saves 9. Thromboprophylaxis and clinical management cannot be overemphasized in the management of patients. Thank you.
Thank you very much. Thank you, Professor Badegeshi and Dr. Liman. We're just going to take just 2 questions. Please, fast, so we can go for lunch. Do we have questions? 2 questions? None? Okay. We started this program at about 25 to 10. We were 2 hours behind schedule when we started. If you look at your time, we are now at 5 p.m. So we have gained 4 hours. So we are now 2 hours ahead. So we're going to go for lunch now. And after lunch, we'll take we hope this is about 2:45. So we are 2 hours, 15 minutes ahead of the program. So we're hoping that we can do lunch between I think the lunch point up, is it ready? Okay. Well, we can do lunch for about 1 hour. So if we can do lunch between now and, we can do it in 45 minutes. Between now and 3:30, then we can start the last phase of the conference, which is a parallel abstract presentations, which is supposed to start at 5. So if we can start at 3:30. So let's proceed for lunch. And we're going to have 3 sessions. 2 of them we hold here. I think 1 we hold here and 2 in Watt Bridge. So which one? So I guess okay. So the session on general obstetrics and fetal-maternal medicine we hold in this main hall. The session on general gynecology, gyne-oncology, urogyne we hold upstairs. No. Shakespeare Hall. Okay, sorry. So the second session on general gynecology and gyne-oncology we hold in Watt Bridge. Okay, so the one in Lugard Hall, that's the oncology one. So the one on infertility and fertility regulation, which in your program is supposed to hold in Shakespeare Hall, we hold upstairs here. Thank you very much.
Once I chop, you are chopping.
I'm complaining. Where did they go now, Liman?
I think we are done.
Wait, you don't chop lunch here. Okay, you want to climb there. Okay. Join us for here now.
Please, you don't want to chop.
I will go chop.
I wish you started to.
Yeah, for no success.
But don't finish.
Thank God.
to this one.
Good evening, everybody. Please, those that have scientific presentations in relation to infertility and fertility regulation should go upstairs. Their presentations are going to be done upstairs, while those for gynecology and gynecological oncology will be done at Woodbridge Hotel. Thank you.
Where?
Have you sent it?
No, there's nothing like that.
Sit down. Sit down. Sit down.
So
Yeah.
I'm waiting for you, man.
Lady, sit down. If everybody sees that, it doesn't not forgive us. Yes, sir. So those that are presenting work in relation to general obstetrics and fetal-maternal medicine are going to do their presentations here. Infertility, fertility regulation upstairs.
Okay.
Then gynecological oncology to general gynecology, Woodbridge. Yes. Sorry, in case a lot of people did not hear me very well, the presentations in relation to infertility and fertility regulation will be done upstairs. Those for general obstetrics, fetal-maternal medicine will be done here, while those for gynecology and gynecological oncology will be at Woodbridge Hotel. Thank you. Prof, welcome. The bag is in the car.
Let me use my.
So once you're ready, I'll get it across.
I'm ready.
Okay, please just give me two. Let me get someone to go and bring it for you. Thank you.
It's too heavy for the phone. It wants to come one-on-one. So let me just use my laptop.
Once you get it, I'm going to tell Atulike to start. Then you go over to the other place. I can stay here. I don't have a problem with this phone. How did you do yesterday? Did you first find out how many of them had presentations?
So we asked them to identify themselves and raise their hand.
Okay, so I can do that now. Before you formally started. Let me see the list. Please, can all those who have presentations here indicate? Let's know how many of us have presentations to make in this hall. 2, okay. Just 2, 3. 3, okay, thank you very much.
Give them, let them start.
Please, those that have abstracts should come and join us at the high table. Those that have abstracts for the general obstetrics and fetal maternal medicine should come and join us on the high table, please. Please, the presenters should come up to the high table. We have 1 minute. Otherwise, we will close the session and go.
Bankole. The author will know his name now. Bankole and others.
Except if you go there and get the slides.
name is.
We need to see the other presenters now. Yeah, welcome to this oral abstract presentation session, the General Obstetrics and Fetal-Maternal Medicine. I'm the co-chair to Professor Emmanuel Yangete, son of the soil. So as directed that I introduce the session. My name is Cyril Dim. So there should be up to about 10 abstracts listed here, but we have about 6 on ground, I learned. Hello? So, yeah. We are waiting for them to upload. Yes. Can we start? The control table. Hello? Can we start? Okay. Yes, that's what we are conferring. So we are going to give each presenter 6 minutes to present the entire work. After 4 minutes, we are going to warn you. And after 6 minutes, we are going to stop. Then the audience will note your questions. You are going to ask the presenters at the end of the entire session. Is that clear? So now we are ready to start. I recognize the president, who is here with us, the VP1 and the Secretary General, and the Assistant Secretary. All welcome, sir. That's where I started. So now we are calling the first presenter, Dr. Iweka R.O., and his topic is Knowledge Uptake, Missed Opportunities of HPV Vaccine in Benin City, a mixed method study. Your time starts now.
Good evening, President Sogon, Mr. Chairman, my teachers, distinguished ladies and gentlemen. I'm Ruben Iweka, and I'll be presenting an abstract titled Knowledge Uptake and Missed Opportunities of Human Papillomavirus Vaccine in Benin City. It's a mixed method study. I'll be presenting using this outline. Human papillomavirus vaccine has shown efficacy against cervical cancer and human papillomavirus-related malignancies. The vaccine was recently introduced in Nigeria last year as a routine immunization for young girls, although it has been in Nigeria, but it was made a routine vaccine for young girls, compulsory for young girls between age of 9 and 14 years late last year. This initiative has prompted mixed reactions based on religious, cultural, myths, and literacy level, including among health workers. So despite efforts of Nigerian governments in sensitizing the masses by creating public awareness, these myths and limitations to acceptance still exist. So we decided to carry out a research aimed at determining the knowledge, acceptance, uptake barriers, and missed opportunities of human papillomavirus vaccine in Benin City. So this study was a mixed method study consisting of both quantitative and qualitative methods. The qualitative method involved focus group discussion and key informant interview, while the quantitative method involved questionnaires. So we carried out these descriptive studies in 4 secondary schools in Benin City, and it was done using a stratified sampling method. So it was a descriptive cross-sectional study, and the period of this study was about 3 months. The total population of persons that were recruited, the secondary school students that were recruited were 801. So like I said, it was a quantitative and qualitative study. The quantitative study involved issuing questionnaires to these students. For those less than 18, we initially gave them a letter to take to their parents to obtain consent from them after getting ethical clearance and clearance from the Ministry of Education in Edo State. While we also gave them later for those parents, because the key informant interview involved phone calls to their parents to interview them on phone. So we also gave them, part of the questionnaire was if they will allow us to call them, which some agreed and many of them declined. But majority of these students, their parents gave them consent to be, asked them to be able to join us in the study, which we went the following day. So we also conducted focus group discussions among the secondary school teachers in these 4 secondary schools. So this is an illustration of how we carried out the focus group discussion. For the 4 secondary schools, we carried out 4. In each school, we had focus group discussions among the teachers where they shared their views concerning the human papilloma virus, the limitations, the acceptance, the uptake. While for the key informant interview, we called the parents on phone, initially obtained consent from them. We also asked them again for those that agreed, and then these interviews were recorded, and then we transcribed them. Then for the data that were collected, for the quantitative data which involved issuing questionnaire to these students, the data was entered into SPSS, and the results are represented in frequencies and table. While for the qualitative analysis, we transcribed this already recorded speech, and then we use the NVivo app to also do further analysis, and the results are presented using prose. So for the knowledge, among the 801 students that were in not really good, because we expected that all these students should have learned about human papillomavirus vaccine. Then only 15.5% of them had good knowledge of what this human papillomavirus vaccine was. Some of them also, they've heard about it, but they knew about the myths that it was harmful, it causes cancer, promiscuity, and others. Then, okay. Then for the uptake of this human papillomavirus vaccine, among those that have heard of the vaccine, only 23% of them had received, which is very low compared to what we were expecting, that since it was being carried out in schools, in public places, most of these students should have been able to get access to this vaccine. So we also explored the reason for their refusal. And the major reason was they were afraid of side effects that may arise as a result of the vaccine, such as fever. And then some of them were afraid of needles, 18.2%, and about 11.3% said they did not know much about the vaccine. Then we tried to explore missed opportunity. Here we define missed opportunity as those students who are within, female students within
round up.
9 and 14
Round up.
years. Okay. So the missed opportunity was 71.3%. So we also did a logistic regression for which the primary level of education for the fathers was statistically significant, and also pupils in rural areas as well were less likely to accept the vaccine. Then we also went further for the qualitative analysis to also find out what these parents, for this focus group discussion for the teachers. And many of them believe that it helps in prevention of cervical cancer. the main benefits is to prevent cervical cancer. And then the myths that was very obvious for this group of persons was that they believe that some of them believe, according to the teachers, say some of the parents believe that it was aimed to kill blacks and reduce population. Then also, the teachers recommended that there is need to build trust among the public and also for public enlightenment. For the knowledge, some of the parents were aware, while some were not fully aware of the vaccine. Then also, those that agreed, some of them also shared their... Okay, in conclusion, Okay, thank you, sir. These are my references. Thank you for listening.
Round of applause for him. Yeah, I gave you extra 1 minute or more because of my bias for your subject. Please sit down. Thank you. The second candidate, if you are here, come up. Please come and tell us what one you're presenting. So thank you, Dr. Iweka, for the presentation. We are going on to the second presentation. The title is Management Challenges of Pregnancy-Associated Breast Cancer in Resource-Poor Setting, a case report. Management Challenges of Pregnancy-Associated Breast Cancer in case report. And our presenter is Dr. Ide B.U. Ide, please,
47.
Yes, number 47. Please project the slide. Look, today you have 6 minutes. We'll remind you after 4 minutes.
Thank you, sir. Good evening, Mr. Chairman, President of Togo, my distinguished...
Wait, they need to. Don't be in a hurry, you've not started.
Good evening, Mr. President, Chairman of the occasion, and my distinguished elders and colleagues. I'm Dr. Ide, resident of University of Benin Teaching Hospital, and I'll be presenting a case report on management challenges of pregnancy-associated breast cancer in a resource-poor setting. This is my outline. Cancers are rare during pregnancy. However, of the cancers that occur in pregnancy, breast cancer has found to be the most common. Pregnancy-associated breast cancer is defined as breast cancer diagnosed first in pregnancy or following the first 1 year postpartum. It comprises 0.2 to 0.4% of all breast cancers, and its average age of occurrence in pregnancy is between 32 to 38 years. There have been no specific risk factors attributed to pregnancy, breast cancer in pregnancy. However, genetic and environmental factors, as in non-pregnant women, have been found to play a role in development of breast cancer during pregnancy. Pregnancy may temporarily increase the risk of breast cancer due to certain physiological changes in the breast, but we have known that generally pregnancy on the long run protects against having breast cancer. Breast cancer in pregnancy is associated with more aggressive subtypes of the disease, such as triple negative and HER2 neu positive, and the patients also tend to present late, contributing to worse prognosis. In low and middle income countries such as Nigeria, lack of awareness, denial of suspicious signs and symptoms, and out-of-pocket spending contribute to delayed presentation and poor compliance with treatment. There are also challenges with imaging and suboptimal staging. I present a case of a 34-year-old unbooked Gravida 3 para 2 plus 0 lady who presented at 28 weeks with a 4-year history of left breast lump and a 2-month history of bloody nipple discharge. The breast lump was first noticed incidentally in the mid-trimester of her first pregnancy and it continued to grow into the second pregnancy and the third one that she presented in. It was painless. She also noticed spontaneous bloody nipple discharge at home. There were no skin changes, no history of trauma to the breast, no family history of malignancies. She had never used hormonal contraceptives. She resorted to topical herbal preparations but presented when symptoms were noted to be worsening. On examination, we found that the breast was twice the size of the right breast with visible superficial veins. There was a mass occupying all the quadrants of the left breast, and there was ipsilateral matted axillary lymph nodes. We made a clinical suspicion of stage 3 breast cancer. We requested for chest X-ray and abdominal ultrasound scan. She also had core needle biopsy done, and the results showed features in keeping with invasive breast carcinoma and no special type. She, however, could not afford immunohistochemistry, would have helped us to know the exact receptor sensitivity. The patient was counseled on the results and the need for mastectomy and chemotherapy. She, however, still delayed presentation for surgery for further 8 weeks because of financial difficulties. She was eventually admitted to the ward at 36 weeks and had left modified radical mastectomy done by the general surgeons. Histology showed the same as the core needle biopsy, which was invasive ductal carcinoma. She made good recovery, was discharged after 10 days by the general surgeons, and chemotherapy was to commence after delivery of the baby since she was close to term. We requested an obstetric ultrasound scan, which showed a breech presenting fetus with no anomalies. We subsequently counseled her for an elective cesarean section, which she had with good neonatal outcome. She was finally discharged home after 3 days and presented 2 weeks for her routine follow-up visit. Generally, the diagnosis of breast cancer in pregnancy is quite challenging due to some alterations in the breast, which include increased tissue density, breast hypertrophy, engorgement, and nipple discharge. Some suspicious masses may be difficult to delineate because of these alterations. Pregnant women who have this disease, they follow the general pattern of presentation, which is a palpable breast lump with or without nipple discharge, as seen in the case I presented. In the postpartum period, they might also present with complaints of milk rejection from the affected breast by the infant. Diagnosis is made following triple assessments as in non-pregnant women, clinical, radiological, and pathological assessments. With clinical suspicion of a breast malignancy, we request ultrasound scan, of which ultrasound scan is done, and mammography can also be done, but it's associated with more false negative results, so we will not want to do mammography in pregnant women. We will also go ahead to do pathological diagnosis, which could be either fine needle aspiration cytology or core needle biopsy. So for this patient, she had astute clinical examination by the general surgeon.
You have 2 more minutes.
It was followed by radiological and pathological assessment. And the results showed invasive ductal carcinoma, no special type, which is the most common histological diagnosis of breast cancer in pregnancy. Breast cancer can be treated despite ongoing pregnancy. There has been no evidence to show that termination of pregnancy affects the prognosis of this disease. Options of treatments are surgery, chemotherapy, radiotherapy, targeted therapy, and hormonal therapy. However, in pregnancy, we stick to surgery, and chemotherapy can be done in the 2nd and 3rd trimesters, and radiotherapy postpartum. The decision to terminate or continue the pregnancy lies heavily on the patient's wishes after multidisciplinary counseling and letting her know that termination does not affect the prognosis. When the patient is at term, it's recommended that the baby is delivered first before treatment begins, and the route of delivery depends on the obstetric outcome. Postpartum, she is counseled on the need for breast milk substitutes because of the effects of chemotherapy and radiotherapy. She has to go through them. Late clinical presentation for breast cancer has been extensively studied as one of the leading causes of high breast cancer morbidity and mortality. It has been attributed to misconception about the disease, poor educational status, cultural beliefs, religious beliefs, fear of losing a breast, and psychosocial factors. As seen in this our patient that presented 4 years after she first noticed the lump. In conclusion, breast cancer in pregnancy is a rare and challenging diagnosis that can be safely managed, especially if diagnosed early. Although detection may occur in advanced stages, aggressive approach will improve prognosis for mother and fetus. Multidisciplinary input is key in its management. Surgery is accepted in all trimesters of pregnancy, while chemotherapy, radiotherapy, hormonal therapy, and targeted therapy have limitations to its use in pregnancy. Termination of pregnancy has not been shown to improve outcome. Hence, pregnancy should be allowed to as near term as possible. And we also advocate for the continued breast examination at the booking clinic. Thank you. These are my references.
Do you have the picture?
She didn't consent.
Thank you, Dr. Ide. No, you can, please, come and join us here. The third presenter, please. The third presenter, tell us their topic. Oh, 46. 46, right?
Yes, sir. Comparative analysis.
Yeah. So, we are going to the third presentation this evening. The title is Comparative Analysis of Pregnancy Complications between sickle cell, HBSS, and HBSC women. A prospective cohort study nested in PIC sickle trial in Nigeria. So the presenter is Dr. Adelabu. Okay.
Good afternoon, President.
You have 6 minutes. 6 minutes.
Good afternoon, the President of SUGON and the Chairman and members on the panel. I'm here to present a study within the trial, PIP-SICKLE trial. My name is Hamid Adelabu. I am Senior Data Manager at the Center for Clinical Trials, Research and Implementation Science, CCTRIS. We are the custodian of the clinical trial. So the co-authors on this trial are renowned researchers and obstetricians from 16 health facilities in Lagos and Osun State, which constitutes LASUT, LUTS, and a few other hospitals, general hospitals in Lagos State. The background. Sickle cell disease is an hereditary hemoglobinopathy affecting African, Mediterranean, and Middle Eastern populations. So it increases pregnancy complication risks, as we already know, and also it carries heightened risks for both mother and fetus. There are limited data on complication patterns specific to HBSS and HBSC pregnancies in African context, particularly in Nigeria. So the objective of this study is to compare and characterize pregnancy complications between HBSS and HBSC genotypes in Nigerian women, which would help to also inform targeted interventions and improving maternal fetal outcomes, particularly in sickle cell disease patients. Methodology overview. The study design prospective, which is a prospective study within trial, like I said earlier on in Lagos and Osun State. Cohorts of 465 pregnant women, 312 HBSS and 153 HBSC were enrolled between 12 and 28 weeks gestational age. We collected demographic characteristics and complications, and analysis was done using Chi-square and Fisher's exact test. There was a study flow chart in the main PIP-SICKLE trial itself. 476 participants were actually enrolled, but for this particular sub-study, we excluded patients with significant medical history such as HIV, diabetes, hypertension, renal disease, sickle cell nephropathy, and hepatitis, bringing us down to eligible participants for the sub-study, 465, and then we did the main analysis on the incidence of maternal complications, risk of neonatal complications in the genotype-specific patterns. So the results. In the two groups, the mean age were quite similar. 29 was the mean age, standard deviation 4.9. And the median parity was also very similar, and the gestational age at enrollment was very much similar as well, at 20 weeks GA. So for the complications in overall,
you have 2 minutes.
HBSS women had significantly higher overall complication risk, and the risk ratio and the confidence intervals are shown. Higher incidence of low birth rates was in HBSS, and that means that it indicates that HBSS women are 2 times more likely to have low birth weight infants compared to HBSC. Severe anemia was also more common in HBSS, and preeclampsia and eclampsia rates were higher in HBSS. There was also a trend towards preterm birth rates. And finally, I would also like to present the risk of PPH, estimated blood loss, and it indicates that there was a risk of PPH which was defined as blood loss at delivery exceeding 500 mils, was also pretty much similar in both groups. So in conclusion, HBSS genotype was associated with higher risk of maternal and neonatal complications. The findings has highlighted the need for tailored and antenatal care plans that should be based on the genotype. So that, let me take that again. Findings highlight that there is need for tailored antenatal care plans based on genotype. And also there is emphasis should be important of close monitoring and targeted interventions for HBSS pregnancies. So these results has provided valuable insights for improving maternal and neonatal outcomes in high-burden settings like Nigeria of sickle cell pregnant women. Finally, acknowledgements, this PIP-SICKLE trial was funded by TED Fund. Thank you for listening.
Thank you. Thank you. Please take your seat on the high table. The next presenter, come up. What's your title?
Maternal outcome of preeclampsia and eclampsia.
Okay.
Good evening, the
Wait,
President.
they need to project the slide. Project the slide.
Okay. Good evening.
So Dr. Ella is going to present the 4th abstract. You may now start, sir.
Thank you, sir. Good evening, the President of Sugon and my very senior colleagues and the members of the panel. I am Eli Sukarime Friday Grant, an associate professor of obstetrics and gynecology at the River State University Teaching Hospital. These are my co-authors, cutting across University of Port Harcourt, and eclampsia are major causes of maternal mortality. Management of patients with these pathologies may require close monitoring and treatment in the intensive care unit for favorable outcome for the mothers and their babies. The objective of the study was to determine the maternal outcome of cases with preeclampsia and eclampsia managed in the intensive care units of the University of Port Harcourt Teaching Hospital, UPTH. The methodology. This was a 10-year retrospective study of all cases of preeclampsia and eclampsia managed in the intensive care unit of UPTH. The information was retrieved from the patient's quiz notes and analyzed using SPSS version 25. A total of 1,549 patients were admitted into the intensive care unit for the period under review, of which 218, 14.1%, were obstetric admissions. 140, represented by 64.2%, were unbooked, while 78, 35.8%, were booked with a mean age of 30 plus or minus 2 years. There were 60 cases of preeclampsia and eclampsia comprising 27.5% of the obstetrics admissions. All 13.7% of the women with eclampsia were booked. The number of maternal deaths from preeclampsia and eclampsia combined were 24, which represented 11% of the obstetrics admissions. In conclusion, maternal mortality from preeclampsia and eclampsia at the intensive care unit of the University of Port Harcourt Teaching Hospital was high. Majority of these patients were unbooked and likely or presented late with complications, thus needing intensive care unit care. Pregnant women should be encouraged to register early and risk assessment for preeclampsia. In addition, measures should be taken to prevent this morbidity. Should they occur, early treatment should be instituted to avert complications and mortality from severe disease conditions. Thank you.
Thank you so much for keeping to time. I learned to have another abstract. Do you mind continuing with that?
Number 67.
Yeah, please, project number 67. Postpartum spontaneous pneumothorax, a case report and literature review.
No, 60, preferred family planning method. Please.
68. Is this 67 or 68?
67. Okay, what? 68, please.
So I'm looking for your name there now.
Okay, but it's projected there.
LES.
Okay, so I go ahead. My topics are preferred family planning methods in pregnant women. Okay. In rural communities in southern Nigeria. This study was combined military hospital Port Harcourt, of which I used to work with them, and also my foundation, the Mother and Baby Care Global Foundation, together with the River State University Teaching Hospital. These are my co-authors. Dr. Abam from University of Port Harcourt Teaching Hospital, Dr. Tay and Professor Ainda in charge of family planning of the University of Port Harcourt Teaching Hospital. And by way of background, the population of developing countries have been on the increase in recent times. This is possibly due to the lack of access to modern methods of family planning. These challenges mostly affect those in the rural areas who are left with traditional methods of family planning options. The aim was to determine the prevalence of preferred family planning methods amongst antenatal clinics attendees in some hospitals in rural communities in southern Nigeria. The methodology. This was a cross-sectional study carried out among antenatal clinic attendees in 4 local government areas in River State, particularly in the Ogoni region of River State. Randomized sampling method was used. This study comprised of 128 consenting antenatal clinic attendees. The information was analyzed using SPSL version 25. The mean age was 29.6 years, while the modal priority was 2. The mean gestational age was 24.9 weeks. The index pregnancies desired by the respondents were 118, representing 92.2%. 121, 94.5% of the respondents were aware of family planning methods, of which 104, 83.3% preferred traditional methods of family planning. The number of respondents that had used family planning in the past were 101, representing 78.69%, though 3, representing 2.3% of the population, used modern methods of family planning. 24, 18.8% of pregnancies were ill-timed. In conclusion, the preferred family planning methods were traditional, with a prevalence of 83.3%. This is worrisome, and efforts should be made by the government and non-governmental organizations to create awareness and improve accessibility to the modern methods of family planning. Thank you.
Thank you so much, Dr. Eli. Actually, this one you presented is not meant for us, but it's okay that you've presented it here. I think it's supposed to be for the infertility group holding somewhere else. I hope they're not searching for you there, sir. Okay. The next title is what?
45. 45.
Your name?
45.
Your name?